Orthopedic doctors discuss hip and knee injuries and
to Queens of Pop. Or unwind to acoustic sounds of the 90s and coffee house classics. New channels, more choices on the SiriusXM app.
The information and opinions expressed on Dr. Radio are intended to address the specific questions asked or situations described on the program and are not designed to constitute advice or recommendations as to any disease, ailment, or physical condition. You should not act or rely upon any information contained in this broadcast without seeking the advice of your personal physician. If you have any questions about the information or opinions expressed during this broadcast, please contact your doctor. Thanks for listening to Dr. Radio.
Get facts, not fear. Dr. Radio brings you everything you need to know about the coronavirus pandemic. SiriusXM 110.
Turn right.
This is SiriusXM Dr. Radio.
From the heart of the NYU Langone Medical Center, this is Healthcare Connect with Andrew Rubin.
Good afternoon and welcome to Healthcare Connect on SiriusXM, Channel 110 Dr. Radio. I'm Andrew Rubin, host of Healthcare Connect, and it's good to be back after our 2-week hiatus. With me in the studio, Allison, navigating the healthcare system in the United States. And Healthcare Connect is the only place, I think it's the only place, where you can actually call in and get those questions answered and hopefully solve some of the problems that you're facing when you're in this crazy healthcare system. So just give us a call at 877-NYU-DOCS, 877-698-3627. Last week, everybody, I got a lot of Twitter messages at our Twitter account at Rubin Health, because that's how people reach us, obviously, when we're not on air and they need help. And a lot of people said, oh, you're on vacation this week. We were not actually, though. We are going to be slacking off. So Allison and I have a day off, so we're not going to actually be able to do the show. So today is the day to call and ask your questions. But then I'm happy to say after that, we're around all summer. Very big news story. Not so much that they upheld it, because I kind of felt that they would uphold it. But I think what happens is that it really put to an end this constant legal court challenges to whether or not the Affordable Care Act should be in place. I think during the height of the pandemic, a huge number, millions upon millions, 30 million people I think signed up, became eligible for the Affordable Care Act that were not previously on it. Like just big numbers of people who got coverage for this. So to kill it would have had a devastating impact on the country. The courts didn't really focus so much on the actual law. They actually can fix some of the things that haven't been working well for so many, like the higher premiums for people who are older and are not eligible for subsidies, or the, as we always talk about in North Carolina, the limited network of doctors and hospitals who take the insurance. So now actually we can put some effort back out that, despite all the challenges to the law by the more conservative people in the country, members of Congress, state attorney generals, etc., they never really put forward a plan to put in its place. So it's not like the public had any choice or ability to choose a different option. Or say, I'm picking on Trump just because it's easy. Trump's plan was better than the Affordable Care Act. There was never a plan. Right. So it didn't really give anybody out there, even commentators on Fox, the opportunity to say, well, this plan would be cheaper, better, stronger. It was this or nothing. So it sort of it weakened their arguments, right? That they couldn't have something to pick from that was better. So it was really just taking millions of people out of the insurance markets that would have needed it. So, hopefully, after today, we won't have to talk about this anymore. We can only talk, we can obviously talk to our listeners and answer questions about, the Affordable Care Act, but we won't have to talk about another assault from Texas, trying to overturn this.
Yeah, and hopefully over time, now that, it's been around for so many years, and as time goes on, when
it's like more than 10 years.
Yeah, yes, and as more people get into these plans, actuaries are able to price out the markets and see what the utilization is. That's, in the beginning when they priced these plans out, nobody knew who the people were that were going to have these kind of plans, which is why you had these like really high deductible plans. You know, there was no way to see for the actuaries what these plans were going to be like and how to price these. Why you had plans going up to a $7,000 deductible. I think at this point we're going to be at a price point where you can say, okay, well, you know what, regulators should really kind of wake up and say, you know what, to the health insurance companies, you know what, now you guys know who's buying these plans. We know who these people are. We know what the marketplace can tolerate. It's kind of time to, I think, maybe like level set a little bit, and you can, I think, go back to them a little bit at some point, and regulate and level set a little bit of what's really an affordable plan at this point. I mean, that's just my opinion, because I could understand the argument from the insurance companies in the beginning saying, hey, look, we don't know what we're getting into here. It's appropriate for us to price the deductible so high. All right, that makes sense. But at this point, you know what? We know what we're getting at this point. You guys know, the insurance companies know exactly who's in these plans, and with the subsidies that are out there, everyone knows who's in the team. So maybe over time, that will be another thing that we're going to see happen. I would hope that at some point, now that you have, again, more providers, more doctors, more hospitals willing to, step into the networks of these plans, that's something that we're going to see change over time as well. You'll have more options of different premium levels, different deductible levels that are more accessible to people. I would hope so.
And honestly, I would expect so at this point.
Yeah.
So we'll see what happens. But either way, some good news. I know we're a week late in reporting it out because we weren't on air last week, but it is finally some good news coming out of this. And remember, the American Recovery Act also built in some additional protections and strengthened some of the weaknesses in the law by improving some of the subsidies and ability for people to get the insurance. It did not address network stability in terms of the doctors and the hospitals who accept that insurance. So people may have been able to afford it a little more easily, but didn't improve the number of people who accepted the insurance. So the doctors that the public could use who take that insurance. But that will all come in time. So incremental steps, baby steps, and certainly some good news to report. All right, phone lines are open, 877-NYE-DOCS, 877-698-3627. I'm Andrew Rubin. This is Healthcare Connect on Sirius XM Channel 110. Dr. Radio, we knew we got a lot of people to talk to because we were off air for the past 2 weeks. So we're going to start with Nancy in Florida. Hey, Nancy.
Hi there. How are you? Thanks for
Good. How are you?
Sure. I'm good. You guys helped me a couple of months ago when I was thinking about putting my husband on Medicare. He's older than me and I'm still working. He's retired. But now that I'm leaning on keeping him on my grid plan, I had a question about HSA. I've been told that I can't participate in our HSA plan. We're on the PPO now because my husband is retired and eligible, Medicare eligible. So even though I'm young and I'm not eligible for Medicare, I can't participate in the HSA. Is that right?
No, it's actually not right, and it's not right for two reasons. So HSAs are individual accounts. So first, if you wanted to participate because you are not on Medicare yet, you can actually participate even if your husband is ineligible. But the eligibility criteria for participation for your husband is not Medicare eligible, it's actually Medicare enrollment. So if he is not enrolled in Medicare Part A or B, so hospital or physician coverage, so if he's opted out completely because he's fully covered under your private insurance, then he can participate in HSA. The day he enrolls in Medicare, any program, Medicare program, A, B, or a Medicare Advantage program, he loses his ability to contribute to the HSA through you. You are viewed separately from him from an HSA perspective. So you can enroll if he does, in fact, decide to enroll in Medicare. So I'm not sure who told you that, Nancy, but they're not correct.
That was actually our insurance broker, which is very surprising.
It is surprising.
Yeah.
I can send you the link on this too.
I know that's really good. I mean, I've always been in the PPO because I like choice, but now that we've added an HSA with an added network component, it's more attractive, and we're making higher contributions. The employer is.
Yeah.
That it's actually attractive, and then so I wanted to participate, and to be told that I couldn't seemed really very weird.
Yeah. So I mean, you got bad information. But so remember, Medicare is individual coverage, so as is the HSA. So you're good to go. And like I said, if you want to message me through Twitter, I can send you the link. You can let's just say your insurance changed next year and you want to go on, he wants to go on Medicare, then you can actually do that and still contribute to the HSA.
Okay. Perfect. Thank you so much. I appreciate it.
You got it, Nancy. Thanks for calling in. Good luck. You got it. Phone lines are open, 877 NYU Docs, 877-698-3627. I'm Andrew Rubin. This is Healthcare Connect on Sirius XM, Channel 110, Dr. Radio, with my co-host, Alice Fogo. I know I have to be so quiet. Emily just brought us cookies, and that is like the best news ever. Because Matt did not bring us cookies. And I brought you cookies this morning for doing this for us. Thank you so much. You totally made my day. Because I actually was hungry today, Matt.
I can't. You told me at 8:45 that you wouldn't be hungry. Don't bring the cookies. So I was a nice person, and I brought the cookies to the people that work for us so they could enjoy the cookies instead.
You brought them down to my team.
I did. I even offered Allison a cookie. She passed up on it. So I'm just, it was a delicious rainbow.
But I'm taking this cookie.
These are good cookies, too.
And they're warm. Wow.
She's offering us more cookies? How many more cookies? There's like 400.
No, I don't need it.
No, we share. We're going to share.
All for one.
Thank you. I appreciate it. All right. Eva from Denver was next. Hi, Eva. Eva? Oh, I went out of order. I'm sorry. But Eva, are you there from Denver?
Yes, I am. Hi, how are you?
Good. How are you?
Good. I hope you're enjoying the cookies.
I am, in case you can't hear.
Just a little bit. I have a quick question, hopefully. So, back in 2019, I had United Healthcare. I had fluid taken out of my shoulder joint, sent to a lab to test if it had bacteria. 2 years later, last month, right now I have Aetna. Same procedure, same place, same hospital, everything. So in 2019, my insurance paid $112 for it. My copay was $1,250. I got a bill. Aetna paid $4,500, and my copay is $450. I know they can have different rates. Is it possible it's 30 plus times more for a simple lab procedure?
That's a good question. That's a very good question. I would like to say it's a mistake, but it may not be a mistake. I was sure the codes that were used were the exact same, meaning they didn't do more things to the fluid to test it. I mean, it's sometimes they say it's the same test, but they might have been looking for something different, which resulted in them doing more. They could have sent it to a hospital lab this time as opposed to a physician lab last time. There could be like lots of different things that could have happened, or it could be as you're describing, it just went up because the hospital had better contracted rates with Aetna than they did for United. But that spread seems really high to me, Matt. What do you think?
Yeah, that seems high to me as well.
Did you see on the claim, did they bill multiple units of the lab code? Is that possible?
So both times, I have both claims, and I've contacted my physician, asked about the codes. They use the same codes. It's the same hospital, same lab, and I know hospital labs are a little bit more expensive than, like LabCorp, for example. I'm in Denver, Colorado. So, but I've already checked that. So the same codes were sent. I did call the hospital and ask them to send documentation from back 2019 and this one just to compare, like code by code. So I'm waiting on that information. I called Aetna and they say, well, it is what it is, and I think they just paid us $4,000, which, I mean, I've paid $400 for like a surgery copay, not for a lab. It just seems a little out there.
It definitely seems a little out there, but it's not impossible.
No.
So you're doing all the right things. You're looking at what was billed. You're going to get a copy of your original bill. You're going to compare it. So a bill will do, the two things will happen when you get the bill that you need to look for. I mean, if you want to send me, take a picture of it and send it to me, I'm happy to take a look. But
Okay.
So one of the things that you want to look at when you get the old statement and the new statement is the charge. So now remember, hospitals don't get paid charges, but you got to follow the steps in what I'm about to describe. So let's just pretend the first time you had this done, if the codes are the same, what are the charges? So what did the hospital charge? Let's just pretend it was $6,000 the first time. Is it $6,000 the second time, or is it $20,000? Charges, not what they got paid, charges. The next thing you want to look at on the bill, and it should map it out. It should actually give you the information. It should say then allowed amount. The next column may say contractual adjustment. It could be one or the other. It could be both. It's usually one or the other. So, but that's basically that column, that descriptor is basically the insurance company's way of saying this is how much we reimburse for this procedure in this location. So you should see what it says on the old bill versus the new bill. So if the charge is the same, but the allowed amount is, or the contractual adjustment is much, if the allowed amount is higher or the contractual adjustment is lower, then you know it's just that the hospital has a better rate with Aetna than they do with the last insurance company. I think you said it was United. But that's how you're going to see if the procedure codes line up, the volume, the number of units. So remember, this is a subtle thing. But when you have a procedure and they take stuff out of your shoulder, I'm saying stuff on purpose because I don't know what it is they actually take out. But they could, depending on how much they take out, they may run multiple tests. So the number of units, the volume of units, they may be different. So even though the codes are the same, but they might have done 10 times the number of analyses on the fluid than they did the first time. So don't just look at the codes used, look at the volume of the volume of codes that were used, and then you'll see. But Aetna's statement that it is what it is what you'd expect them to say. Yeah, these are the rates, this is what we paid, and this is why things are so expensive in this country. I mean, there are times, I'm not going to say what procedure, I'm not going to give, but there are times where, hospitals get paid 6, 10, 12, 15 times what Medicare pays. Not 30 times what Medicare pays, but 6 times what Medicare pays, or 8 times what Medicare pays. So, the numbers you're describing are not impossible. And then one last thing, like I said, if you go to a LabCorp makes, they do very well. Quest, LabCorp, how they do well, it's all automated, very automated, and they have such enormous volume. And hospital labs are different than LabCorp, as you point out. So you can have the same blood test and have your blood sent to a hospital lab. It doesn't happen as much anymore, but it can happen where it's, $1,000 gets reimbursed at the hospital, where LabCorp might have gotten $80. So that's also a possibility. So you thought it was going to the hospital lab, but the hospital then got it and sent it out to a third-party lab. So because there's sometimes where a hospital doesn't have all the equipment or what they need to do to run the specimens, and then they send it out. So it looks like the hospital did it, but the lab is actually a third-party lab.
So one last question is: right now I see that there were 8 tests done each time for 8 different types of bacteria. I can see that information on the between the 2 times they did it. So I know that. So is there any way to appeal it to the hospital and say, hey guys, last time it was $100, right now you're charging $4,000, or it doesn't matter because it's different insurance, they wouldn't care?
I want to make sure I have the hospital real allowed amount was how much the first time?
The first time, the allowed amount my insurance United paid was $112. My 10% was $12.50. This time it was $4,500, and my 10% is $450.
Wait, it seems like a scam. Something changed.
Something changed, but again, it's a totally different payer. So it's a different contract it's being reimbursed under a totally different contract.
I can see this happening.
I can see it happening too. So it's a different contract that the hospital has with a different health plan. So it's totally different scenario. And again, you're saying that there's a different number of tests that were being run on the specimen. So there's a clinical.
But when I think about it, sometimes, you know, when these contracts get negotiated, and I don't want to give away all the industry secrets, but, you know, a hospital might be able to jam a list of codes into a new fee schedule that result in something like this, but then other things come out. So, you know, with Aetna, they may get $4,000 for this, but they only get $20 for something else. Whereas with United, they got $2,000 for that something else, and they get, you know, and they got.
Their delivery rates for OB services may be lower with Aetna than they are with United, and their lab rates may be higher with one payer compared to the other. So it's like, you know.
Yes, but that spread is still like, this is what we do, Allison. We don't have a spread that's 400 times off, right? I mean.
Correct. but also, the last thing you did say was that the number of times that the lab specimen was run was different, right?
No, it was the same. It was 8 and 8.
Yeah, 8 and 8 to go up.
8 and 8 each time. Same test, same time. You know, yeah.
And you sure? And the first time the first bill you're talking about was definitely from a hospital lab, not the pathologist, not for the reading of it.
No, same place, same everything. Same physician even took out the fluid, same place as before my MRI, sent to the same hospital. It's identical. My surgeon uses the same. I mean, I talked to them extensively, but I thought I would give you a call because, you know, I thought, well.
It's possible, but this spread, as Matt points out.
Yeah, it's something.
So do me a favor, just send us, you know, send me a Twitter. You can black out your name if you don't want to send me your name, or certainly black out any, you know, account numbers and stuff like that, just because you're sending it through Twitter. But send me a copy of the actual codes bill, the loud amounts. I do want to see it, and what I'm actually going to do is I'm going to run it up against our contracts and see. But it's not. What Allison's saying is it's not impossible.
It's not impossible. It's definitely not impossible that their contracts from one carrier to another vary that differently. But
Matt is not agreeing. But
no, it's sure. Is it possible? Sure. There's no law that says it can't be like that. But I mean, we wouldn't have a fee schedule that's so different like that. That's $100 to $4,000. We wouldn't have the same thing that different. We wouldn't.
Normally, no, but it could happen.
Well,
It
I appreciate that it could happen, and that there's no laws that prevent it, and there's no negotiation that prevents it from happening, and we could do the same thing.
Not necessarily intentionally, but I mean, there could be something that it could be a code in a contract that for some reason, you know, whatever. It could happen. It's not going to happen over time.
I could see it happening, and I could see the meeting we would have when we found out it happened.
Yeah.
You would look at the two of us and say, "How did you let this happen?"
I would say, "How would you let this happen?" And then I'd say, "But don't change it."
Get the other one up.
Exactly. Why? No, I want to know why an insurance company would pay me $4,000.
I can think of how a scenario like that would happen. I mean, I can explain it to you out there. Like, I mean, I can tell you exactly how.
Get it, but
me too.
Yeah.
So, you know, send us the stuff. I do want to take a look at it. I don't honestly think appealing it with the hospital is going to work. You call that, no, this is what they allowed. It's an approved claim. It seems like a lot to me to have pathology specimens. What you could do is you call the hospital and complain about the copay and see if they'll give you an adjustment. Sometimes, you know, based on, you know, labs and things like that, we always told people, make sure you know when your labs are going. But like if you go to a physician office and your insurance plan says you're contracted, you have to send your blood work to Quest, and then the doctor's office is part of the hospital system, and they send it to the hospital lab, you know, you can end up with $1,000 copay or $600. You know, that's when these examples happen, and that's where I have seen this happen. And the hospitals, we will typically, you know, because a patient, you know, got into this bind, we will typically make an adjustment. You know, so I do think you might have a shot at appealing your co-insurance amount because you didn't know this. But fighting it with Aetna, having them approved it, I wouldn't. But I do want to see the statements because something's not adding up.
Yeah, definitely. And you know, I didn't even flag it because last time I paid so little, when I knew it would be going to the same place. Both insurance plans are really good health plans. I never would have thought.
I have to be honest with you. It seems that the first one seems a little low to me. The second one seems very high to me. So I don't exactly know what's going. A lot of hospitals, in terms of taking, sending, a lot of fluids that get sent don't even get checked anymore. So there's, I don't want to get too technical, but I was actually talking to the head of clinical pathology literally 2 days ago, and there are a lot of hospitals that have exemptions on what they even send to the lab. Like, it's not 100% clear to me that they needed to send 8 specimens to the lab for fluid taken out of your shoulder, unless you have some family history of some kind, or
it was a post-surgical infection. That's why they had to check it.
And it happened twice.
It's still not resolved, so that's why we have to repeat it.
Interesting.
Yeah.
Interesting.
2 years later. It's not good. Not good.
That's not good. That isn't good. So the infection is still there?
That's what my surgeon thinks. That's why it went back. Yeah.
Yeah, I've heard of these random things happening. All right. Well, good luck on that part.
Thank you.
So at Ribbon Health, send me photos of those DOBs. I want the explanation of benefits. So Ali and I want to look at them and see what they say, and then I'll message you back. Don't send direct message it to me. There's a way on Twitter to actually send a direct message. Don't post it on my Twitter page, because then everybody will send it to me.
Thank you so much for your time.
All right, Eva. We'll talk to you soon. We'll talk to you off air. My phone lines are open, 877-NYU Docs, 877-698-3627. I'm Andrew Rubin. This is Healthcare Connect on Sirius XM Channel 110, Dr. Radio. Tina from Wisconsin is next. Hey, Tina.
Hey there. My husband turned 65 this year. He's been on disability for, I don't know, a decade. With Social Security, so he's been on Medicare.
Okay. What's wrong with him? What's his disability?
Rheumatoid arthritis. He's got 5 types of arthritis.
Okay.
It's a primary thing, but so up until April 1st, he was on my insurance through my employer. I retired on disability with my employer, and
what's the matter with what happened to you?
A brain surgery, cognitive deficit issues.
Okay.
I couldn't do my job anymore.
Okay.
So, big long story, but anyway, we're explaining one of the problems. Okay, I'll get there. So, we changed to, so I'm on my insurance, he's on as a Medigap now.
So he's on Medicare and on your insurance?
On my insurance with Medigap. So we're on separate policies now.
Yeah, but what you're describing is not possible. So
yes,
I work
for a state government.
Okay, so you work for the state. You retired from them with disability, and
yes.
But Medigap is supplemental insurance. So what's your primary insurance?
It's an HMO through the state.
HMO Medicare Advantage?
Mine's not Medicare yet, because the disability is only through the employer at this point. My Social Security application, you have a 6-month waiting period and all that.
Okay, so then who's on Medigap? Your husband you're talking about?
My husband.
Okay,
Yes.
okay. So he's on your insurance, and then he also carries Medicare?
Yeah.
Oh, got it. Okay, and he has Medigap?
Yeah. It's,
okay. Okay, we're getting there. All right. So then, what's the question?
So he'll turn 65 in November. Do we have to contact Social Security? Because there's a thing. Because the Part D, he doesn't have the that with Medicare. That's under my my state plan.
Yeah. So when you come off your state plan and he no longer has access to your prescription drugs, that he'll qualify for a special enrollment. You don't need to contact you wouldn't contact Social Security. You'd actually contact a Part D carrier, Part D prescription drug carrier. They may ask you for proof of eligibility.
Yeah,
and you have all that, I'm sure. So then he should be able to enroll with no problem. Then he'll pick up Part D prescription drugs, and that'll happen. I would do that, a month or two before he comes off your prescription drug plan. And if that's happening now, then I would encourage him to call now.
I have sick leave conversion that'll come.
Yeah, all right, so you have some time. Good.
And then hopefully my Medicare will be approved by the time my sick leave conversion is. It
should. It's usually, just so you understand how it works, it's usually, just so you know how it works, when you go out of disability, between sick leave, short-term disability, long-term disability, it's designed to, the timelines for insurance are designed to allow the Medicare or the insurance to kick in. So you should be the dates should work okay for you. They usually do.
My pension was higher than my short and long-term disability, so because of we tried a demotion first.
Okay.
And our pension is based on our 3 highest years, so it's based on the disability plus the 3 highest years when I used to.
Yep, I know what that is. Yep.
And then
okay, so we got your husband squared away. Does that
cool.
answer the question?
That's great. It does. Thank you so much.
All right, Tina. Good luck, and I hope you feel well, and good luck with your transition over to Medicare and disability. So we do need to take a quick break here on Healthcare Connect, Sirius XM Channel 110, Dr. Radio. I'm Andrew Rubin with my co-host Allison Vogel and Matt Pencer. We're going to be right back after this quick message.
Today I don't feel like doing anything. I just wanna lay in my bed. Don't feel like picking up my phone, so leave a message at the tone. 'Cause today I swear I'm not.
Never miss a beat of Dr. Radio with the new Sirius XM app. Streaming now included with most Sirius XM subscriptions. Go to SiriusXM.com/more. Sirius XM celebrates Black Music Month with Black Music Forever. A limited edition channel with hip-hop, R&B hits, and reggae music from Black artists. On now, Channel 105. Plus, all month long, hear new Sirius XM shows from Andrew Day, Her, and more. SiriusXM.com/Black Music Month for more info.
Saturday on Dr. Radio at 2 p.m. East, plastic surgeon Dr. Nolan Karp reviews the latest cosmetic surgeries and procedures, including lasers, implants, facial rejuvenation, and body contouring. At 4 p.m., summer has arrived. Dr. Mark Chapin discusses the important steps that will keep you healthy during this season of high heat, humidity, sun exposure, and other outdoor safety risks. Then at 10 p.m. East, Dr. Stacy Loeb hosts the Men's Health Show and discusses diet and kidney health. That's just some of what's happening Saturday on Sirius XM Dr. Radio.
Hey everybody, I'm Kenny Chess.
Everything gets hotter when the sun goes down.
No Shoes Radio is a reflection of my life, songs from my friends and heroes. Hi, it's Joe Wash. Red Rocker Sammy Hagar here, and I got my shoes on. You're going to hear me sing songs with those friends and heroes.
Stevie Guitar Roller, big old jam.
Sirius XM brings you channels you can't hear anywhere else.
No Shoes Radio.
Exclusively on Sirius XM Channel 57.
This is an important message from the CDC on managing stress. Don't underestimate the impact your own stress may have on your child. Children and teens may have a stronger response to crisis. Signs of stress may include sleep disruption, increased social isolation, self-harm, or use of drugs or alcohol. If you're concerned your child is showing signs of severe depression or having thoughts of suicide, get help immediately. Reach out to your healthcare provider or call 911.
A voice for the voiceless. Just because you're in the ghetto doesn't mean we can't. From struggle, things from wrong, we blame our survival. And swag. Sirius XM presents a new limited edition channel dedicated to the life and music of Tupac School. The Tupac Channel in honor of Black Music Month on now. Channel 104 and on the Sirius XM app. Coronavirus, what you need to know now.
should be telling people that you do get freedom with this vaccine, and this vaccine makes it so much easier to go back to your routine in a safe manner. People that are vaccinated basically have very little to worry about. Being around other vaccinated people for sure, being around unvaccinated people because they're unlikely to be a spreader. These really are path-breaking vaccines, and they will put the pandemic behind us, so you should get your vaccine when it's your turn.
Hear the latest updates about COVID-19 on SiriusXM Doctor Radio.
Recognizing the efforts of the healthcare workers and researchers helping us through this coronavirus pandemic. This is Dr. Radio, Sirius XM 110.
Welcome back to Healthcare Connect on SiriusXM, Channel 110 Dr. Radio. I'm Andrew Rubin, host of Healthcare Connect. Thanks for tuning in. Our phone lines are open 877 NYU Docs, 877-698-3627. If you're out there trying to get through the healthcare system, understanding what kind of insurance you need, healthcare benefits, insurance claims that are all messed up, Medicare, Medigap, Medicare Advantage, you name it. So much to think about when you're selecting health insurance for yourself, for your family, for your spouse. So we're here to make all that easier. It's as simple as calling 877 NYU Docs, 877-698-3627. With me in the studio, I have my great team, my co-hosts Alice Global and Matt Pencer. Alan and Matt, thanks for being with me today. Busy day. We've been off air for the past 2 weeks, so we got a lot of catching up to do, and we're going to do that. We're going to start with Lynn, who I accidentally skipped over by mistake last time. So Lynn from Florida. Hi, Lynn. What's up?
That's okay. I'll forgive you.
Thank you. I appreciate that.
Sure. I've listened to you guys all the time, and you've helped me once before. We have a 23-year-old daughter, who probably are getting the idea already, who's graduating from college, or she just graduated from college. And she had her health plan through the university, and it's ending the end of July.
Okay.
So,
What university? What university is it?
Nova University in Fort Lauderdale. Wow.
Okay. No, but yeah, I know. Yeah. So it's good insurance?
It was. And it's better than what her dad and I have, which is why we don't
Okay.
my husband retired a few years ago, so we're in that, 62-year-old
Yeah.
situation where, anyway, we were able to get a plan for us, which is fine, but we don't want to put her on ours. So I've been looking on the marketplace, and I actually think we've sort of chosen a plan, but I just sort of want to get your,
Okay.
your
So I'm just real fast, just before you even give me the specifics on the plan. What did your daughter graduate college? What's her degree? What's her
Oh my
career
goodness.
plan?
Well, she graduated in criminal justice, but
Okay.
does not want to do anything in criminal justice.
Okay.
So right now she's working in retail until she figures out exactly what she wants to do.
And she lives in the Fort Lauderdale area. Where do you guys live?
Yes, she lives in an apartment, in Fort Lauderdale.
Gotcha. And they don't have benefits at the retail place?
Yeah. And I don't think
Come work for me in Boynton.
Oh,
We
yeah.
have good health insurance.
That sounds great. I like Let me
Call her, message me.
He's serious.
I'm actually serious. You should message me through Twitter, and I'll have her send me a resume. We have a big contact center down there with great career paths, great benefits. I'm not kidding. I mean, listen, why not?
I'm going to.
I'm quite serious. I was reading CNN.com. Do you know this story?
No.
I was reading CNN.com a few months ago because we opened up a big back office in Las Vegas, Nevada, and this was during the pandemic, how a lot of people were out of work because of COVID and the casinos, the tourism, tanked obviously, and they profiled a woman who had a good job and how she was struggling, and I sent that article to my recruitment team in Las Vegas, and we hired her. She's now the office manager at our site. Yeah, true story. I mean, so if we're hiring there, it's in Boynton Beach, which is 20-25 minutes away from Fort Lauderdale. She's got a college degree. We have good jobs off her. She's called me about insurance. We have great health insurance. Why not? And she's doing retail. I'd rather have her work for an agent. I'd make more money too. and have a potential career path. So anyway, then that's not your question, but.
But no, I'm definitely going to contact you about that. What's the name? I mean,
You just go on Twitter and you type in @ and then Ruben Health, and then my profile will come up, and then there's a place that says send a direct message. You just click on that, and then you just type in. You know, you can, if you want to attach her resume, I'd rather you just give me her name and contact info, and then someone will reach out to her.
awesome. Yes, I will do that. Thank you.
Okay, cool.
In the meantime,
In the meantime, go ahead. I'm sorry. Sorry, everyone else, but I'm doing some recruiting here. But go ahead.
I appreciate that very much. She does qualify for a pretty big subsidy of $331.
Okay.
She has about 136 options, but you know, very quickly you can narrow those down. That's my question to you. I'm a Florida Blue Girl or a United Healthcare. That's generally the coverage we've had.
Yep.
But there is no option for United Healthcare, and the Florida Blue Care's plans are really high. But
Yep.
there's a Cigna Connect Silver EPO plan,
Okay.
which looks great on here. I mean, as far as she has, with her subsidy is zero deductible, $1,500, maximum out of pocket. There's very low copays, that type of thing. But it's like, because, and this is what I've noticed for a lot of the Cigna plans, they're new plan, not rated. And so I don't,
Yeah. So a lot of insurance companies that stayed out of the marketplace for a while, or were on the marketplaces and left, are coming back. I'm pretty sure United's coming back to New York as well. So I've been hearing about a lot of insurance companies that are re-entering the marketplace. So it's not surprising that they don't have reviews. Here's what I can tell you about Sylva, though. It's an excellent insurance company, so I have no doubt in their ability to deliver a product that works. The only thing that's important for you, particularly for your daughter, particularly since it's new, is to look at who as in which providers and which hospitals have signed up to take the insurance. So, I don't know where
yeah, I've done that.
So have they? Do they? I mean, your daughter's healthy, right? So I mean, but.
Yeah.
Do the doctors you'd want her to see in the event of emergency take this Cigna? You can't look and say, do they take Cigna? It has to be Cigna, whatever word you just used. I don't remember the actual name of the product.
I think it's pretty good because it, you can also apply the filters with the providers, and there's the Broward Health is a big healthcare
Yep.
system in Broward, and many hospitals. All the hospitals under Broward Health are in that plan. Holy Cross Hospital, which is one of the hospitals we've used in the past a lot, is not, but I don't see that as a detriment to her. She easily use one of these others. And we check doctors. There's a couple doctors that aren't, but it's not a big deal. She can find a new dermatologist, that sort of thing. I think that's about it. I really kind of just wanted to hear your confirmation because I thought Cigna was a good.
Yeah, I wouldn't get caught up on the plan ratings on healthcare.gov. As Andrew said, new plans, aren't rated yet just because there's no history. But, Cigna is Cigna, right? So just because it's a different product of Cigna that isn't rated, if you have experience with Cigna, that's a big national company. That's good, right? Eventually, when this product gets rated, I'm sure it's going to be rated well, right?
Well, it's going to be rated based on the network, So
there's factors that go into it.
Yeah, there's many factors, but but one could expect if you've done the research and that the doctors take it, then it's going to be a good plan. Go ahead, man. I'm sorry to interrupt.
No. I mean, it's my point being, big name brand companies that you know of that have doctors and hospitals in your area. That's what to go with. Don't get caught up on the rating that it's not rated. What could this mean, right? You're asking the right questions. I think you're looking at this the right way. If the doctors and hospitals in your area take the insurance for her outside of just a dermatologist, you can find another dermatologist, right? If she was getting some Right, if she was getting some intense specialty care because something was wrong with her, God forbid, we'd feel differently, right? You know, but a dermatologist, you can find a dermatologist. Sorry.
And I will say this just for you know, out there, I'm always gonna, at least for now, I'm always gonna tell you that employer insurance is usually gonna have the best, broadest networks of doctors. I mean, it's definitely more expensive. It can be more expensive for the employee through the payroll contributions. It's certainly more expensive for the employer, but you'll always get the sort of the bigger national networks on there. You could have a high deductible, lots of things. But that being said, if you're on the exchange and you're going with an exchange product, you have to make sure everyone's in, because you usually don't have out-of-network benefits on the exchange plans. And if you're comfortable with the network, then most of the plans on the exchange are going to be pretty good. Cigna in particular. Okay.
Okay, sounds good.
All right, Lynn. I'll look forward to hearing from your daughter, or you.
Okay.
All right. Okay, sounds good.
Thanks, guys.
All right, Lynn. Thanks for calling in. Phone lines are open. 877 NYU Docs. 877-698-3627. This is Healthcare Connect. I'm Andrew Rubin, host of Healthcare Connect, with my co-host Allison Bowl and Matt Pensler. I have found many good people through Dr. Radio who still work with us.
You just shouldn't have a team that recruits for you, because you're clearly the better recruiter.
I mean, we have 500 people there. I know. We're looking for another couple hundred, and plus there's always turnover. So and it's a great place to work. So why not push it?
And you can see Andrew's face on occasion when he comes down to the office.
I do go down there periodically.
We're going down, right? We're going down in the fall.
You're going to the CBO West.
Oh, that's right. We're going west. We're going west.
Oh, me too.
Yeah. We're
We'll
going
see.
too.
So I bring the cookies next time.
Okay, Laura from Illinois is next. Hey, Laura.
Hi, I have a question about which is possible. When Corona hit, my husband and I took out of work for 3 months. Our business was closed, and we're both high risk, so I left my employment on a personal leave.
Okay.
So
You say it was your own business? You say it was your own business, or you work for what do you do?
I work for an employer, but my husband has his business, so he was on my insurance.
Okay.
From my employer. Okay,
Gotcha.
so then
Where did you work? I'm just trying to get some. It always helps me to have some background. Where did you work? Did you work for an office? You were in a restaurant? When you left, because you're high risk, where were you working?
You say the name of the company?
Yeah, it's okay. It doesn't matter.
UPS.
Okay, so you never closed down during COVID, which is why I was asking.
Oh no, we're essential workers.
Yeah.
But I left because I'm high risk and
I got it.
getting sick. So the thing is, I was fortunate enough that they gave me time off. They never gave personal leave in the past, but I was fortunate enough to take time off, and I paid my share for a time, and then they said, well, if you're going to stay out, you can, but you'll have to take COBRA. So I did that, and I put my husband on Medicare because he was eligible, and it was cheaper than putting him on COBRA with me.
Mm-hmm.
But now I've returned back to work.
Good.
And left him on Medicare, and I'm back on my plan. No more COBRA.
Right.
So my question is, can I put him back on my plan and leave Medicare, or is he stuck on Medicare now?
No, he can absolutely. I know he can absolutely drop off Medicare and go back on your insurance. 100% okay. And he can do it at any time, because you're going back on insurance as a qualifying event. So you just have to coordinate with your employer. Once he's locked in on your employer's insurance, then he would drop his Medicare. But I wouldn't drop it until you're all set with your employer.
Right, I have to wait until re-enrollment for next year because...
No. Well, I don't think so, and that's where I was going next. So,
Well, I've been back at work now since March.
you've been back at work since March. Yeah, then you're gonna have to wait till. Then you're definitely gonna have to wait till open enrollment. You missed your qualifying event window. It's
For work, like
well, March, April, May. Yeah, it's usually 3 months. It's usually 90 days. So, depending when in March this happened, you might still squeak through, but open enrollment's around the corner too. So it's not like you're You know, it's not like you're locked in. He's locked in forever. But it's usually 90 days, so you can check if you're within 90 days. Given that it's for the end of June, you've probably missed your window. But and then you'll just do it. You'll do it in the fall with open enrollment.
I can do it in the fall. So.
Oh, absolutely, absolutely. And then just a quick question: when he signed up for Medicare, he went with traditional Medicare.
He did Part A, which I know you can't get off of that, which is fine. He could.
Well, you can, but you don't need to. But you can.
That's fine. I'd rather he be honest.
Exactly. And so Part B is the doctors.
Yes, I put him on Part B, and I put him on the Advantage plan.
You mean no? No. Advantage plan is all-encompassing. So you put him on the Medigap plan, you mean?
I don't know what Medigap means. I put him on. He pays $144 a month, I think it is, and then he also $38 for United Healthcare Advantage plan, which includes his medication. Okay,
so he's not on traditional Medicare. He's on a Medicare Advantage. That's the nuance. So, so you'll just contact United Medicare Advantage when it's time, and you'll disenroll him because he's going to be on your private insurance, and then you'll re-enroll him when and if you retire.
Right.
Okay.
Right. But yeah, I think when I retire, I can only get coverage for myself, not him.
How long have you been at UPS?
20 years.
Yeah, so I don't know what your retirement benefits will be, but I know that they're usually pretty good. So
give you credit, there's things, yeah.
Yeah, exactly. So you'll see. I mean, you can call us back. They'll send you all the information, but re-enrolling him in Medicare is not going to be difficult.
Okay, great. So, and as long as he's on my plan, he won't get penalized with.
Nope, he will not get penalized. Not at all. Correct.
I guess that's it. I had something in mind, but I forgot.
Were you? I was curious. Were you? Well, you can always message me too through Twitter. Were you? I'm just curious. Were you? Did you furlough yourself, or did you actually take a leave, like a FMLA?
It started out kind of in error. But they gave us a letter that said if you were high risk or had COVID, you could take 2 weeks off or something. So I started out like that. I had talked to my doctor. He sent in paperwork. Somehow I ended up on disability. So I got that for a month, and then they called and said, no, you have to, for high risk, you have to just pay your benefits and go on personal leave. So
okay, so you were on leave. That's all it was. Okay. All right, but then
October when that ran out.
Yeah, I gotcha. And then they took you right back. So you weren't let go. You just sort of
Same job, everything.
All right, good. So so they handled it well. Good. That's what I was trying to figure out. Were you furloughed? Did you go on leave? Were you just FMLA? What was your status?
Yeah.
All right. Well, you're back now. We're all back. You're vaccinated, right?
Yeah, double vaccinated, the whole family. I've got my son was a pharmacist, so he wouldn't have it any other way.
All right, good. Yeah, no, I would have spent a lot of time talking to you about it if you weren't. So I'm glad you're back at work. We got your husband straightened out. You're vaccinated. Country's back. Thank God for UPS. You guys were amazing during the pandemic. So it's good to be back, right?
It really is. It really is.
Yeah. All right, Laura, thanks for calling in.
Thank you.
All right, take care. Phone lines are open, 877-NYU-DOCS, 877-698-3627. I'm Andrew Rubin. You're listening to Healthcare Connect on Sirius XM, Channel 110, Dr. Radio. I'm with my co-hosts, Allison Vogel and Matt Pensner. We are live today, Thursday, the end of June, 12 noon East to 2 p.m. East. We replay throughout the week, but, this is like I say all the time. It's not Thursday, and it's not between 12 and 2 Eastern Standard Time. And guess what? You're listening to the show on a replay. and as I said, next week, which is coming up on July 4th, we're going to be off air. So I think next week is July 1st, or it could be the last June 3rd. I don't know. Whatever it is, we're not going to be live. So if you can't wait message us to Twitter, through Twitter, at Ruben Health is how you reach us. And it's a great way to reach us when we're not on air. So, of course, the best way to get us is when we're on air, and we're going to take a quick break now, and we're going to come right back after this quick message.
Summer is here, and we've got music channels on the Sirius XM app to help you beat the heat in many different ways. Sing-along hits for your great getaways on Road Trip Radio. Sun-soaked reggae sounds on the joint. Waste Away Again with Jimmy Buffett on Margaritaville. So many more channels to enjoy the summer. All on the Sirius XM app.
Sirius XM and NYU Langone Health present a new podcast, Vital Signs, where medicine is made personal.
I basically died 7 times.
I called my husband and I said, it's cancer.
Featuring some of NYU's world-class physicians telling their own extraordinary stories.
This was the first time I was really scared.
He jumped right and said, "Oh my God," he opened his eyes. Vital Signs, a new podcast from Sirius XM and NYU Langone Health. Subscribe now on the all-new Sirius XM app.
Sit back, let go, and slip into a commercial-free stream of deep house and down-tempo grooves. Sirius XM. Modern mood music for focus, relaxation, and inspiration. Sirius XM Chill, Channel 53. Or download the Sirius XM app to listen outside of the car.
Hey, it's Madison, the Black Eagle. The American Red Cross is facing a severe blood shortage and is urging eligible donors to give now and help avoid delays in life-saving medical care for patients. More donations are needed to replenish the blood supply right now. Be a hero to a patient in need. Use the Blood Donor app. Visit redcrossblood.org or call 1-800-RED-CROSS to make an appointment to help save lives.
The Stanley Cup playoffs are on Sirius XM. The mission to hoist the World Stanley's Cup. The assignment: win 16 games. Vanquish 4 opponents. Lift 33 pounds of silver above your head. Hear every second of the Stanley Cup playoffs on Sirius XM and your hometown announcers on the SXM app. Free for most subscribers. Coronavirus. What you need to know now.
The big effort now is not just to help people understand that a failure to vaccinate anywhere in the world is a failure to vaccinate everywhere. We've got to have a global approach to vaccination, and vaccinating ourselves nationally is very important, but contributing to an international effort to vaccinate is also extremely important here when you're dealing with a pandemic.
Hear the latest updates about COVID-19 on Sirius XM Doctor Radio.
Get the information you need to stay healthy as we move toward the end of this coronavirus pandemic. Sirius XM 110.
You're listening to Healthcare Connect with Andrew Rubin on Doctor Radio.
Welcome back to Healthcare Connect on Sirius XM Channel 110 Doctor Radio. I'm Andrew Rubin, host of Healthcare Connect. Thanks for tuning in. Our phone lines are open, 877-NYU-DOCS, 877-698-3627. With me in the studio, my co-host Allison Ensner. Allie and Matt, thanks for being with me today, as always. If you're out there trying to navigate the healthcare system, understanding your insurance benefits, Medicare, Medicaid, exchange plans, moving out of state, furloughed, turning 65, going on Medicare, whatever it is, wherever you're struggling to figure out how to best protect yourself, your family, your loved ones, we're here to make it easier to understand. And it's as simple as calling us at 877-NYU-DOCS. All right, we're going to keep going with the phones. We've been super busy today, and as always, we start with Bridget in California. Hey, Bridget.
Hi, good morning from, sunny Southern California.
West Coast. Is it still hot out there?
Yeah, the sun is over here.
Did it cool down a little bit?
I guess 67 maybe, but it'll climb up into the 80s in a few
Yeah, but
hours.
that's not 110 like it was last week, so that's good. All right, what's up?
So I have a question. I DM'd you last week regarding a infertility coverage issue, and I was hoping that you would help me navigate it.
Go ahead. Sure.
It has to do with my sister. Her coverage is the Kaiser EPO. I know that you responded to me and mentioned that EPOs are excellent, but in her case, when it comes to accessing services, whether it's a consult for infertility treatment, or if she were to have to go down the path of IVF or something like that, the EPO under the Los Angeles Archdiocese does not cover those type of family planning services. So I was hoping that you can help me navigate the issue and explore some options on how to go down this infertility coverage route.
Well, tell me what the challenge is. I mean, so California, like, go ahead. You go first.
No, I'm sorry. Go ahead.
No, I was gonna say. I mean, California, like New York, mandates coverage for IVF, which is in vitro fertilization. But an EPO is merely a plan that says you have to stay in your healthcare network. You just don't need a referral to see a specialist. So basically, EPO doesn't give you out-of-network benefits. It gives you the ability to not need a primary care gatekeeper.
Yeah, but is the issue really that the Archdiocese has carved it out?
That's where I was
And
thinking.
is that the issue, that they have an exemption to not have the coverage, so she doesn't have any coverage no matter where she goes? Is that what she's bumping into?
Yes, that is the issue. Not even for a consult.
I thought they have to supplement them with something else. Was that
I thought in New York that's what they have to do.
Yeah.
Right? I don't know if that's a federal thing, but in New York, right, it doesn't have to be their insurance company that covers it. They like carve it out to another one, so it's not like under their plan. It's under someone else's.
What's the actual question? I mean, so
can she get benefits to pay for it?
What options does she have in order to be able to access and have?
she has to. She could drop her insurance and buy another plan in California on the exchange. She'd have to pay full price because she wouldn't be eligible for a subsidy, or she could leave. She could leave the Archdiocese and go work for an employer that has the coverage.
Got it. So there isn't any other.
In New York State, I don't know that there's are religious organizations able to carve this out?
They are, but
Then they have to like load it into a different plan, basically.
Exactly. Right. So so if you work for a religious organization, they don't have to cover it under their plan, but another plan would pick it up for you under like you'd have you as the employee you would still have coverage for that benefit, like
So does it have
contraceptive
that
or something.
California?
I think that's what that's what I'm trying to figure out.
I don't know.
So yeah, so like your employer doesn't have to cover that benefit for you.
Well, then who pays for the coverage?
It's
really just a back end. It makes it feel like
So the
church isn't, but they
are through their arrangements with the insurance.
Exactly.
Yeah,
Exactly.
it's still covered.
I'm going to assume California has a similar legislation. Has she contacted the insurance company, Bridget, to see what her options are with insurance? Like what has happened so far?
So when she's spoken to the administration above her, they pretty much just reiterate that it's because of the limitations in coverage due to religious beliefs for healthy family planning. So it doesn't cover birth control, it doesn't cover IVF, it doesn't even cover consult. So that's the information she received last week. So that's when I reached out to you. But we don't know in what direction to go to. Should she go to HR? Should she go to... I know that I perused through the manual with regard to the options for coverage, but it didn't really delineate when it came to anything having to do with IVF or infertility.
Yeah, there's no extra mandate. It doesn't look like in California that religious groups can be exempted from it in total, from what I'm finding.
Now, what does she do? I'm curious. What does she do for the Archdiocese?
She is a kindergarten teacher.
Okay. Has she looked at being a kindergarten teacher in a non-Catholic school?
She has, but she's currently completing a master's in credential program, a dual program at a private institution, and they're covering a portion of her tuition, and so she is contractually obligated to continue with the institution for X amount of years since they are covering X amount of tuition. So that's one of the situations that she's in as a result of.
How old is she, Bridget?
35.
All right. And has she she's been trying to get pregnant and is now not able, so she needs the consult. Is that where we're at in her journey so far?
So she just wanted to start by proactively starting to look at so she's at the age where she's like, okay, I'm 35, I'm going to have a family with my partner. I think now is the time to start having these conversations. But when she spoke to her OBGYN, she had mentioned like we wouldn't even refer you for a consult because of the type of coverage that you had. So that's why we are in this situation as of last week.
Yeah. Gotcha. All right. I'm trying to think. I mean, just to be clear, I mean, these mandates for IVF coverage are relatively new, and many employers prior to the mandate, certainly in California and New York State, never actually included IVF coverage in their policies, which is why IVF has always been so expensive for so many. So, I hate to say it, but, if she wants to have kids and she's having trouble or she needs the assistance of an IVF clinic, it's probably worth her getting a consult now and seeing at least what the lay of the land is and getting the price structure. But, she might just have to pay out of pocket for it, which is what a lot of people used to do in this country, and quite frankly, a lot of people still do in this country, because they don't have that coverage available to them. It's not a great answer, but it's also, quite frankly, up until a couple of years ago, was basically all we did here, even at NYU. We didn't have coverage, but now we do, obviously, and it's different, but that's a relatively new thing. So, she could go online and find a clinic near her and find out what a consult would cost.
Yeah, I mean that's really the options, right? Is go and figure it out and see if they can afford it.
I mean, if she doesn't have the coverage,
and she wants it, you pay for it, right? I mean,
and she wouldn't be able, since it's part of a carve-out plan, she wouldn't have the option to purchase just that.
No. I mean, think about it, because no company would sell it, because you're trying to get pregnant. You're trying to get pregnant, so they would charge her $20,000 for the policy because they know they're going to be spending $20,000 to get her pregnant. So it doesn't work that way.
Got it. Well, thank you so much for the information.
I'm sorry.
Everyone's input.
I know she's in school, but maybe she can pick up a part-time job that has.
昨天你说那警察被搭理，那逮着了吗？现在罚的老狠了，好几百。
Maybe find a job that does offer better benefits, and she can keep doing her kindergarten teaching. I don't know how much her school commitments are in terms of time, but if she has more time in her day, she could pick up the hours and get an insurance plan that way.
Yeah, I heard you mention that a few weeks ago to a younger caller that could potentially be an option.
I feel bad. It's frustrating that this is exempted for her, but that's the downside in working for that kind of organization.
Organization, indeed. Okay, well, thank you so much. I really appreciate it. And as a social worker, all of your input that you share every week, the team, all of the consults and everything has been so beneficial for me as a social worker in serving so many here now that for me. So once again, thank you so much for taking my questions today.
All right. Well, thank you for sending that. And we're rooting for your sister. I mean, it's a tough situation. I mean, religious organizations can be exempt. We have great coverage here, obviously, for our employees, but not everybody has such robust benefits like that. It's not a mandate under. Are the ACA plans, are they required to have them?
I think they are outside of the exemption.
That's exemption. That's
Federal
really
exemption.
No, I didn't know if it was a federal.
Yeah, the regular plans that you would buy on the exchange would have that coverage, yeah.
Okay. But then you get into, does anyone take those plans?
Well, right. So you may be able to buy it, but if nobody in your local area accepts those plans, then it's just as good as not having it, right? Or if you happen to work, because that's where you found work, at a religious place that has an exemption, you don't have it then either, right? So, there's all these little loopholes and nuances to things, right? So everything sounds great until...
And I think actually that was challenged in court, and I think that was upheld. That was upheld by the courts.
Right.
But they can carve it out.
It makes sense. It's expensive. This stuff is also expensive. They're doing it on religious grounds, but there are economic grounds too. I mean, these are expensive services to cover. All right, phone lines are open, 877 NY Docs, 877-698-3627. I'm Andrew Rubin. You're listening to Healthcare Connect on Sirius XM Channel 110, Dr. Radio, joined in the studio with my co-hosts Allison Bogle and Matt Pensner. Okay, next was Ann from Rhode Island. Hey, Ann.
Hi, how are you doing?
Good, how are you?
I'm doing well, thank you. I have
What's
a
cooking?
quick question. I have Medicare as my primary, and then I
Okay.
have Plan G as my secondary. I had a physical on January 20th, and I'm getting two bills. One is a facility charge, and one is just the balance that goes towards my deductible from my primary doctor.
Yeah.
And I'm not quite sure on the facility charge what that's all about, and nobody can seem to give me an answer. I didn't know if you had heard of such a thing.
Oh, I've definitely heard of such a thing. Where did you go for your physical?
Care New England in Providence is where my primary is.
Okay, so that...
The charge is through Women and Infants.
Yeah, so is the doctor's office on the hospital grounds?
No, it's not on it's across the street, so I don't know if that's considered hospital.
Yeah, the doctor is part of the hospital group, so what you're being billed for is the time. So this is a relatively new thing. For routine medical care, we tend to not have it set up this way for us here in New York, but it does happen around the country. When your doctor joined the hospital group, or maybe they were always part of the hospital group, this is a hospital location. It's a hospital facility, so the doctor actually works for the hospital. And because the service was provided in a hospital location, they are allowed to bill for the services that the hospital provided separate from the services that the physician provided. So I assume you were put in the room and then a nurse came in and checked your blood pressure and all that stuff before the doctor came in?
Correct.
Yeah, so all the activity that took place during your exam before the doctor came in and did her or his exam, I don't know what sex your doctor is, would be billable under a facility fee. It's usually a much smaller amount than the doctor bill. It's usually, and it's usually billed on levels based on the amount of work that was done, workup that was done. It's usually a level 1, which is just, temperature check and blood pressure screening and all that other stuff. I'm curious how much the bill is for.
The service and charges are $195 for
From the
charge. I'm being billed $63.30. Now the doctor service charge is $176 for the actual doctor, and I'm being billed $69.85. So the facilities charge is about $20 more than the doctor. So
when you say give me the doctor charge again, it's $175.
The bill under the doctor says services and charges $176.
And what was the Medicare allowable amount?
Payments and adjustments $195.
Yeah, there's not enough detail on that because you haven't met your deductible yet, right?
No, this will go towards my deductible. Which
Yeah, that's why because technically you're so for Medigap they should have picked up all of the balance, and the only reason they wouldn't pick that up is because you haven't reached your deductible yet, and the balance, and so that's why it's a larger portion. You have a Medicare deductible, and then and the Part G doesn't cover the Medicare deductible, so that's what you're paying for. The hospital charge is, to be honest with you, it's not illegal. I will tell you that in New York State they're very strict. They require places that do it this way to make sure that there are signs posted all over the waiting room, that you signed a piece of paper when you came into the facility that you read that says you're in a hospital facility and you're going to get a hospital bill for your services that are provided in addition to your doctor bill. Do you know, or do you recall if you signed any of those things or saw any of those signs?
I've been going to her for so long, so I really don't know.
And it was new this year?
Yeah, this is the first time I've gotten a facilities charge.
Did she move into a new location?
About maybe 2 years ago she did.
Yeah, so that probably probably the way the timing worked out from your last visit. Yeah, so, I mean, you can call the hospital and make sure you have a full accounting for what this is, but again, my hunch is when you checked in, did you sign a whole bunch of papers?
No, because I've been going there for so long that I really don't sign anything when I go in now, so. But I will call them and find out more.
Yeah, I mean, if this is the first time and it's not posted and clearly and not posted and you didn't sign anything that acknowledged it, you could certainly protest it. I mean, it has. This is not an unusual occurrence as more and more physicians get hired by hospital groups, and like I said, if it's for routine healthcare, not something that's happening in the operating rooms and stuff like that, the hospital has a responsibility to sort of explain this to their patients up front. And if they didn't do that for you, then I think it's worth complaining and pushing this and seeing if forcing them into telling people that this is happening, and secondly, protesting this payment because you didn't expect it.
Okay. Yeah,
all right.
I will give them a call. Yes, thank you so much for your help.
All right, Ann, let us know how this goes. I would not, I mean, you might end up having to pay it, but I'd like you to at least push back a little bit because I don't like when this happens.
Yeah, okay, I definitely will. Thank you again.
You got it. Good luck. This has happened. We get complaints, in our cancer center is a hospital outpatient program. We don't do this for primary care.
Yeah, that's I think the wrinkle that for some people, even for me,
I'm not 100% sure why they would do that in primary care. It seems a little unfair to me. But in a cancer center where you're getting a higher level of care because you have cancer, that a lot of those programs are in hospital outpatient locations, and the clinical team is doing more than is doing work in addition to the physician. So it makes sense to me.
Right.
So, and that's how we do it here.
Yeah, we have criteria as well.
We have criteria, but even then, Allie, we've got this posted everywhere. Patients sign a piece of paper. It's electronic, but they are told when they're signing what it is. So we go out of our way, I guess. What I'm saying is to make sure that our patients are informed about what's happening.
Because I think that the thing that you don't realize as a patient is like you're walking into a regular doctor office, right? Like nothing feels different. Sometimes, as they describe, this is across the street from the hospital, right? You're not going into a hospital, right? You're going into what you think is a regular doctor office, and then surprise, after 50 years, now all of a sudden you have a facility claim, right? And you were going to what you thought was a doctor office. So doing this on primary care, for me personally, my opinion is it feels a little edgy, right?
Totally, I agree. And not only that, the fact that it was higher than the doctor charge. Usually these facility fees are lower than the doctor charge because what do you pay for? You pay for the room, You're paying for the nurse's time and things like that, but those are lower. The doctor piece is the expensive piece.
And that's the thing that people don't understand. Usually when you're in a hospital building, the nurses are employed by the hospital, and that's the difference too. People don't really understand that piece of it. The nurses, the physician assistants, it's the physician extenders, those ancillary providers, they're employed by the hospital, not by, and the doctors are separate.
Yeah, and also these places have to be certified by various accrediting agencies, so they do meet a higher level of standard of care, right? It's not,
Absolutely.
There are different things in there, even though you may not see it,
Right.
but there are different things in there that make this closer to a hospital setting than a physician office, right? Whether it's the safety measures, protocols and things like that, those are all there. And part of the facility bill is to cover those extra resources.
Except you wouldn't tend to see that in primary care centers.
Yes, totally agree. I still go back to that, right? This is a little, to me, on the edge of okay. It's not something we would do and currently don't do, right? It's our cancer centers and things like that.
Or cardiac imaging centers and things like that.
Right. It's places that have a different level of care.
Advanced level of care that's needed.
Right.
All right, phone lines are open, 877 NYU Docs, 877-698-3627. I'm Andrew Rubin. This is Healthcare Connect on Sirius XM Channel 110, Dr. Radio. Next is Arlene from South Carolina. Hey, Arlene.
Hello. Thank you so much for your help.
Sure, what's cooking?
I am calling for my daughter.
Okay.
She is in North Carolina and has her insurance through Blue Cross Blue Shield on the marketplace.
Okay.
She was in the hospital on March the 21st, in March of 21, and with a high fever due to an infection. She went to the emergency room and was very careful to go to the hospital in her network in Raleigh.
Right.
Now we're getting bills from the Physician Association that were the emergency doctors who treated her. They will not and I have called 4 times to talk to them. I've talked with the insurance company, and they have called the Physician Association, and they just will not buy it. The obvious thing is for me to pay it and then file a claim to be reimbursed. But that's not allowed with Blue Cross Blue Shield if the hospital is in network.
No, the doctors are separate. The doctor bill is a separate claim from the hospital bill, so there should be no reason why you can't submit the claim for the physician component.
Well, I mean, the bigger problem that you're going to have here.
There's a problem,
The problem is that it's possible that because the doctor's group is out of network and she's getting her insurance to the exchange, that the doctor group doesn't take that insurance and her exchange plan doesn't have any coverage.
There's going to be no benefit.
There's going to be no, right, I think you're going to...
It's an emergency, they have to pay the claim. If the emergency visit is covered, the prudent person, they have to cover the ER claim and they have to cover all the ancillary services associated with that ER visit.
Yeah, but they could pay a fraction of it, obviously, right?
She shouldn't be able to.
They won't even
Well, that's going to be a fight.
They won't even file it.
No, right, that's a different. And so and North Carolina, they won't let you file the claim.
They will not accept the claim from me because, or from my daughter. They will not accept it because this hospital is in network. It has to be out of network for me to file personally.
That's what Blue Cross is telling you? Blue Cross of North Carolina is telling you that?
Yes.
That I've never heard of before.
It's on the claim form. That's why it caught my eye when I filled out.
I'd go to like the Attorney General's office at that point.
It makes, you're stuck in a loop here that doesn't even make sense. So
it is.
So when you call Blue Cross Blue Shield, and explain to them the situation, what did they tell you to do? They have to tell you what to do.
They know that she told me, let me talk to them. So she left me on the phone while she went to talk to them. And she said, okay, I have it all straightened out. I have told them what they need to do, where they need to send it, her number, everything. And she said, I even added her member number to the end of it. They are on it. They're going to file it. That was 6 weeks ago.
They have no incentive to do it. They're not going to do it. They have no incentive.
That's right.
I would call the hospital. I would call the hospital.
I tried that, and they told me that they are not responsible for this group. They
好像有点你
do.
看着挺火的。
Well, they're not. That's just BS. That hospital has the. I have to tell you, it amazes me how hospitals in this country get away with the crap that they get away with. I mean, that would never ever happen here. It would never. Because if I were the hospital executive, I would throw that group out of my hospital so fast for treating my patients that way. It's ridiculous. I'm trying to. There has to be a pathway out of this. I am convinced. Does she have an insurance card from Blue Cross Blue Shield? And is there an address on where to mail a claim form to on the back of it?
Yes. Yes, and I gave it to the doctor's group. And
No. You just. You have a copy of the claim form?
I have a copy of the individual claim form.
Yeah, mail it into the address on the back of the card.
Yeah, I actually just Googled Blue Cross Blue Shield North Carolina member claim form, and I found something that's called member claim form. There's nothing on here that I'm looking at that says you can't submit this if the hospital's in network. It just asks you to put your member information in, the insurance information, and then mail this form, itemized receipts, and the explanation of benefits, if applicable, too. And it gives the address in Durham, North Carolina.
Okay, it's on the form that I have, and I have it in front of me, but I can't find it right now.
That's all right. Just Google.
It may say that on all the forms. It may say that on the bill, but there's an address on the back of the claim card.
Yeah.
Just send the claim. Just send the claim into that address. Send it in certified mail, and I bet you it gets processed. Now, it may get processed with a very low dollar amount, but at least do that. And when you call the hospital, you just call the billing office.
这都是那个川普的铁粉。
Yeah, why don't you try? Is this a big hospital in North Carolina?
Yeah, it's huge.
那两个到多少钱
So
了？
why don't you try and
都
reach?
抵着道了，对吧？
There's usually patient advocacy departments. You can try the executive administration. I would call the president's office. I mean, if a call came in like this to our CEO, and this was going on, I would get that email so fast saying, what the hell is going on here? And I would be responsible for fixing it. And then I would get in touch with my billing department, and I have a big one, and I would lay into them and saying, what are you doing? So, it is unconscionable that they're putting you into this maze. Yeah.
这地方基
I'm
本
not
上都是
100% sure you just spoke to the wrong people who were just, unwilling to help. I would escalate this for sure. I would raise this to the hospital administration and their patient advocacy department, not their billing department. And I would send the claim in to the address on the back of that card.
Okay.
You have a bill. You have insurance. It was an emergency case. You have a card, an insurance card. You're allowed to send in a claim form. The hospital being in network or out of network has nothing to do with it. If this were a hospital emergency room charge, then that's right. Right, and I understand that. But the person who thinks they're helping you, who spoke to the physician group, billing department, is probably not understanding that it's a private group. You would think that they would understand that, but my hunch is they don't understand it. Because if the physician group doesn't have a contract with Blue Cross Blue Shield, which they don't, they are under no obligation to do anything.
Right.
Okay? It stinks that the hospital uses a group like this. Because again, when a hospital doesn't have the physicians on staff or part of the group to cover it, they frequently go to third-party providers, anesthesia companies, emergency medicine companies, pathology, whatever radiology, whatever service a hospital can't provide. And there are national companies that provide emergency room physicians for hospitals that don't have their own group. It's not uncommon. But the hospital is responsible for the quality of the doctors and responsible for the quality of the services provided by the groups that are sitting in their hospital. So, it may not be their doctors, it may be separate billing, but they do have a responsibility to make sure that the doctors don't treat their patients poorly, because it's a reflection on the hospital. So I would pursue this. I would, certainly go to the patient advocacy department. Every hospital's got them. I would certainly go try and get, the CEO's email and email him and tell them what's going on, or her, and tell them what's going on. And at the same time, an insurance company has to accept the claim. If you have a claim that for an out-of-network service, even though you have no out-of-network benefits, but it's an emergency, and there's an address on the back of the insurance card, you can mail that claim and send it certified mail, and it will get processed.
Okay, all right. They're just telling me that because she's in network.
But she's not in network. The doctor's not in network. That's my point. The hospital's in network. The doctor's out of network. And this person who is at Blue Cross Blue Shield doesn't understand that the doctor is out of network. There's no contractual relationship with the doctor and this insurance company. They don't have to do anything. So when she thought she was helping you, she thought this doctor was in network, so she thought she was providing the information to this group to help you, but she was doing absolutely nothing.
I remember in 6 months there's now a national surprise bill law that goes into effect.
什么意思？
Nothing's going to help out.
This is not going to help you.
照相啊？
This is not a surprise bill.
Well,
录像还是照相啊？
I think it's an surprise. I mean, we knew we were going to be billed for
那
medical
这
care
直
at
接
the
就照呀。
hospital.
我看
Yeah,
见
but you
当
just
时
know
有
they
个
were
标
out
志
of
道，
network.
不知道是什么，我看不清。照相
They
啊？
haven't told
那
us.
也得照一下。
Every time I call, they tell me we're on it, we see it, we got it, we're on it.
yeah, they're just
Yeah, that's
full of it.
Yeah.
Okay, all right, that's what I think too. But
Okay.
it's
哦，那
not
个相
something
片
we get
直接就
reimbursed.
跟手上的相片里。
No, exactly. The only way you can get reimbursed is by sending the claim form in yourself.
Okay.
And don't expect a ton of money back, because even though it's an emergency, they're just going to pay. We'll see what they pay. We'll see what they actually cover. And also, they're not obligated to cover the whole amount. They're
Yeah,
just not.
I understand that. But they
We'll have to
do
negotiate the insurance company.
because it's an
The bottom line here is the patient is not responsible. So the doctor group has to negotiate with the insurance company and get her out of it. Don't pay the bill to the doctor group. This was an emergency.
Right.
What was the emergency? Did you say what the emergency? Did you say what the emergency was?
She had a fever that was really high due to an infection.
Yeah, that's an emergency, so it'll be covered.
They're to pay the hospital.
Okay.
Yeah.
Right. And the surprise bill has to.
Everybody's been paid except this group. And
Yeah, but they haven't been paid because they haven't filed an insurance claim yet.
Should be paid.
Send it in. Send it in.
they're filing.
All right. Yeah, you send it in. They're not filing. You send it in.
Will do.
All right, I'm stressed out, Arlene. You stressed me out. So get this
这个
resolved,
这个地
okay?
方停过车，
Will do. Thank you.
All right, good luck. Don't give up.
这个绿房
All
那
right,
个
we're going to take a quick break here on Healthcare Connect, Sirius XM Channel 110, Dr. Radio. I'm Andrew Rubin, host of Healthcare Connect with my co-hosts Allison Vogel and Matt Penzer. That's just wrong, by the way. That should not happen
So many levels.
in this day and age. And I should have asked her what hospital. We should have done a public shaming of that hospital. All right, we'll be right back after this quick message.
Sirius XM Streaming now included with most Sirius XM subscriptions. Go to SiriusXM.com/more.
我不这个是。
I'm Jason Stein, journalist and publisher at Automotive News. Join me this Thursday for a new show called Cars and Culture. Each week, I'll be talking with celebrities, business leaders, and sports icons to explore America's passion for the automobile and the culture those leaders create.
This week's guest is American professional football executive and former quarterback John Elway Jr.
Cars and Culture at 7 p.m. Eastern Time on Sirius XM Business Radio and available on the Sirius XM app.
Saturday on Dr. Radio at 6 a.m. East, our orthopedic doctors discuss hip and knee injuries and when joint replacement surgery is necessary. At 8 a.m., dermatologist Dr. Evan Reeder reviews the latest information on acne, melasma, and rosacea. Then at 10 a.m. East, if your child's face is buried in their smartphone, you can put that technology to good use. Our pediatricians review the best apps and devices that will keep kids entertained and learning all summer long. That's just some of what's happening Saturday on Sirius XM Dr. Radio.
This is an important message from the CDC on managing stress. Stress can cause fear and worry about personal health and safety, your financial situation, and the loss of support services. This anxiety can be overwhelming, cause strong emotions. But speaking with a trained counselor can help. Your healthcare provider can help you find confidential resources that can aid in managing your stress. Go to cdc.gov for more information. That's
试试
cdc.gov.
哦。这里是统
Sirius XM brings you more new comedy.
道上
Comedy
的那
Central
个
Radio, Laugh
盖个
USA,
帽。
Raw Dog Comedy, more exclusive comedy.
Netflix is a joke.
这3期邮价怎么算贵？
More classic
可
comedy.
能都一样。
Harlan's Corner, more down-home comedy. Jeff and Larry's Comedy Roundup. Yeah. And more stuff you can't hear anywhere else. Sirius XM Comedy, channels 93 to 99 and online. Sirius XM presents an all-new exclusive podcast. Comic-Con begins. Comics, science fiction, monster movies, Star Trek, fantasy, Star Wars. Learn how a group of high school comic book fans to the back of a dirty bookstore started what became the biggest annual pop culture event in the world. Just are winning Hollywood now. Comic-Con changed my life. Comic-Con begins, a 6-part series. All episodes available to binge now on the SiriusXM app. Download today, free for most subscribers. Coronavirus, what you need to know now.
If you do have more moderate symptoms or you're not sure if you need to see a doctor, call ahead. Call your doctor, call the emergency room where you're thinking about going and say, this is what I have, what should I do? And if you do come in, they expect you and they will help expediting getting you into isolation to minimize the chance that you're going to spread the infection that you might have to other people.
Get the latest updates from Dr. Radio around the clock on SiriusXM Channel 110. Recognizing the efforts of the healthcare workers and researchers helping us through this coronavirus pandemic. This is Dr. Radio, SiriusXM 110.
Welcome back to Healthcare Connect on SiriusXM Channel 110 Dr. Radio. I'm Andrew Rubin, host of Healthcare Connect. Thanks for tuning in. With my full team here today, Allison Vogel, Matt Panzerelli. Matt, thanks for being with me. Lots and lots of questions, navigating the healthcare system, lots of callers. We want to get through as many as we can, so we're going to go back to our phone lines. And we're going to start with Julie in Florida. Hey, Julie.
Hi there. How are you today?
Good. How you doing?
Good. Thank you for taking my call. I have probably, well, it's a basic question, but I'm hoping you can help.
Sure.
So it dawned on me that I am a stay-at-home mom, and we have followed my husband's career, and so we've been on his insurance.
Okay.
And we're about 9 years apart. And so I'm thinking as he approaches retirement,
How old is he?
He's 62.
Okay.
So
I don't know how old you are now, too.
Now, you do.
Okay.
And so he says he wants to work until he dies because he loves what he does. But at some point in time, I'm thinking he might want to retire. But the point being is, let's say he retires at 65. Let's say he retires at 70. There's still that gap. And so it dawned on me that, I've got to come up with some insurance. So, talked to a financial planner, and they're like, yeah, you just plan for that and set that money aside. But I was wondering, if there's stuff, can you recommend some resources that I should be looking into to read up and become knowledgeable and to better educate myself?
Yeah, I can give you some. I think everybody needs to know about their health insurance and what's available to them. The reality on the ground is, no matter what happens with your husband, when you get closer to when he gets closer to retirement, whenever that is, there's really going to probably only be one. If you're not working, there's only going to be one option available for you, and that option is going to be healthcare.gov, which is also a terrific website that I haven't been to in a long time, but when healthcare reform first came out, Allie, Matt, and I literally lived. It was called the KFF, the letter KFF, the Kaiser Family Foundation.org, and and that gives you, I think it's probably the best source for healthcare access, Affordable Care Act, healthcare regulation, but in simple English, and it explains all the nuances to how to get health insurance, what it should cost you, what are the shortcomings of the insurance, and you can search within their website for it. If you're just looking for insurance to say what's going to be available to me when my husband finally retires, literally the best place for that is healthcare.gov, because that's the marketplace where all the different insurance products are sold. So if you're just trying to learn about healthcare, I love kff.org. If you're trying to learn about what insurance plans are available to you in the market in your region, it's healthcare.gov. But if there's something that that's just making you want to ask the question you're asking me, you should ask me now. Like, what is it? I have to say, I get a lot of calls, but I haven't gotten one like this in a really, really long time. So what is it that made you, I don't want to say worried, but thought about that this was something that you needed to call in to ask me today? Something's bothering you? So what is it that's bothering you?
Well, I think what's probably bothering me personally is the fact that I should have prepared for this a long time ago. And I'm like, oops.
I'm not sure that there would have been anything for you to compare or prepared for, because you can't necessarily do anything until a declaration is made. If you're not eligible for a subsidy because your income is too high, then you'll still buy insurance on the marketplace. You'll just pay the full price of it. If you're eligible for a subsidy because your income's too low, then you'll just get the same insurance. It'll just cost you less.
Right.
So I don't know that there's anything to prepare for. Sure, I mean, of course, save as much money as you can. I mean, as we get older, one of the things about health care reform, health insurance, is I'd say the people who have the hardest time dealing with healthcare insurance in this country are people who are outside of the subsidy range and who are older. So when I say older, you and I are actually the same age. If I wanted to retire, at 60, and I didn't have an option to retire through my employer with their insurance, and I went onto the marketplace, up until fairly recently, and recently is defined as the American Rescue Plan by President Biden, my insurance could have cost me $20,000 a year because I wouldn't be eligible for a subsidy, and I'd have to buy insurance on the exchange. Now, under the American Rescue Plan, it's capped at 8 or 8.5% of my modified adjusted gross income. So if I were retired, that would presumably be lower, and I would be eligible for a subsidy because they essentially expanded the subsidy levels. So, there's, other than saving money to be able to retire early, I'm not sure there's much you can do to prepare if you're not going to be getting a subsidy.
Right.
So the next... And I was just say this, my dad, and this is very common, I think, since you and I are the same age, I could say that of our parents' generation, it is very common to have a parent who is older than the other. So my dad is 83, my mom is 78, but my dad retired at age 68, and my mom was therefore age 63. So she had 2 years before she was eligible for Medicare, and when my father's employment insurance stopped working. So they had and the Affordable Care Act didn't exist, and my mom has pre-existing health care conditions. So I'm not going to get into all the things that they did, but they had to work out an arrangement with my father's medical group to be able to keep keep their insurance going for my mother. Until she became eligible for either COBRA, which is 18 months, or eligible for, Medicare on her own. So you have to plan it. I think it's easier to plan now because you have the Affordable Care Act options. But it is something that you will eventually need to deal with because eventually he will stop working. And if he works forever and you make it to 65, you're great. If he stops before then you'll either go on COBRA or you'll go on the Affordable Care Act. But you shouldn't worry about it.
Yeah, thank you. And so the next best thing, or not the next best thing, but one thing to do is go on that healthcare.gov and then just compare the plans. Because part of the challenge is kind of looking into the future. Like, what if I...
Yeah, I mean, the problem you're going to have on healthcare.gov is anything you see there now is not going to be necessarily even the same next November when they upload the plans from 2022, let alone what it's going to look like in 2028 when your husband may or may not retire, right? So the only reason I tell you to go look at healthcare.gov now is just because you seem inquisitive and it's like you want to learn more. So I think it's great that you are, and I think it's great that you're interested in this, and I think everybody needs to be interested in this. So it's good that you're thinking about it. On the flip side, there's not much you can do other than educate yourself right now, and know that all the dollars and premiums are going to change over time anyway.
Right, and stay as healthy as you can.
Exactly. Well, that I would say for anybody, right?
Go without saying.
Yeah.
Well, thank you all for what you do. I so enjoy your show. I'm driving cross country, and I have listened. I've learned so much.
What are you driving cross country for? What are you doing?
I'm gonna go visit my dad.
So where's your dad?
He's in Oklahoma.
Wow. So you're driving from where in Florida are you?
I'm actually in Arkansas. As I call.
Okay, but where did you start from?
Fort Myers.
Good for you. That's quite a drive. My parents used to drive to Florida from Florida to visit my sister in New Orleans. I guess it's what, like 24 hours? How many hours to Oklahoma? 30 hours from Fort Myers?
14 plus 21.
21. God bless you. I don't know how. If I'm in a car for more than 2 hours, I get antsy.
I could never see traveling with you that far.
My parents would do it overnight. You know, they would make it an overnight trip, but no, we won't let them do that. It's just too far. I think it was like 18 hours. It's too long. Plus, anyway, Julie, drive safely and have a good.
You get to become a little expert on a little bit of.
You're an expert on everything. It's good stuff. I'm telling you.
Smarter.
It's really good stuff. Anyway, Julie, drive safely. I'm glad you called. All right, you got it. Take care. Phone lines are open, 877 NYE Docs, 877-698-367. This is Healthcare Connect with Alice Vogel, Matt Pencer, and I'm Andrew Rubin. Next is Ray from Virginia. Hey, Ray.
Hello, doctors. Can you hear me?
I can hear you. What's cooking? Not doctors, but next best thing. What can we do?
Okay. Great program.
Thanks.
Back to the situation about the billing, from the outpatient, getting a medical bill and supposed to be lab bill.
Yeah.
I see my endocrinologist is outpatient. I get a medical bill from them for $97. Then I get another charge for $255. So it's a total, $158, totally $255.
You got it from the hospital?
Well, they're not in the hospital. They're right next to the hospital. What they say that charge is, it's their rental space. And
No, that's not right. I'm sure it is. It's what they mean to say is it's the overhead. So the hospital is allowed to bill, going back to that caller, I think it was 2 or 3 callers ago, the hospital's allowed to bill what we call a facility charge. A facility charge includes, it includes the rent, it includes whatever facility costs they have, they're allowed to recoup. So I think they're just using bad terminology to describe it to you. The doctor's not actually billing you, it's the hospital that's billing you. And it doesn't have to be in the physical... Yeah, and it doesn't have to be in the physical hospital. If it's a hospital licensed facility, and that could be, 100 feet from the hospital, it could be 20 miles from the hospital. It just depends on where it is. Then the hospital is allowed to send a facility fee, and when you spoke to whomever you spoke to or called or who you've ever called, they would have said something like, yeah, that's our overhead, that's our rent, and things like that. But it's bad phrasing. It's bad phrasing, but it does happen, and it is. I will say this: it is becoming more and more common, and I could easily see this being something that gets regulated away. It is confusing for patients. It has increased the cost of healthcare services, and I think there are aspects of it. I understand why we do it. I understand there are locations where it's appropriate and not appropriate, but it's very confusing to patients, and it's something that the government's going to have to say we're not going to allow it anymore.
Well, and when you hear like our other caller, when it's happening in primary care physicians' offices, that's where someone's going to start to pay attention and say, you pushed this too far, folks, right? We're going to regulate it. Whereas if you just left it at cancer centers, you may have seen that for a long time. But once this starts happening, advocacy groups will start going crazy.
Be like, no more, we're done.
Yeah, I agree.
All right.
I do have one more quick question.
Sure. What's up?
马上就开2个小时了。
I had fallacious headache, so I went to the emergency room. The insurance paid the
回家走的时候，
bill,
它那
but
个
they
显
did
示
not pay the
2小时
radiologist
28
because
分。
they were, again, just like the other one, out of network. So on paying them, they actually, I didn't realize this, they sent me the collection
35分钟。
for the radiologist bill, so I'm paying
显示是
on
8点
that.
25到，不是33分钟的。
No. It's just like we told the other caller.
True.
The insurance should be paying for both of them. What kind of insurance do you have?
5点50多点
Is it an HMO? Is it a PPO
5
plan?
点54，出门的。
No, it's not.
行吧，
Okay.
是，因为走
It
的
doesn't
那
matter. If it's an
个
emergency, another
那
bill
边
is
聊到了，
paid.
别扯那阵儿。
They should pay for the reading of the imaging.
Right.
那个
Did
园
the
区
radiologist submit a claim to Blue Cross for you,
园
or
区
they just sent you a
了，
bill? That was
是
it.
吧？
I believe they just, I don't think they did anything. They just sent me the
汽
bill.
车的，
And but it didn't come until later on because they sent me the collection. So I didn't even get that bill till later. You know what I mean? For them to send it to
应
collection.
该是53。
So first, I think you should call the collection company and try and put a hold to it and say we got to work this out and we
现在
got
正好跑了
to
100
submit a claim to Blue Cross and then
现在是
whatever's
46
remaining we can figure out how to
36
pay.
嘛，跟那个路。
But you got to get yourself out of collections first, right? So that would be my first call.
The story on my credit.
Exactly. And then I think you got to make sure that that claim went to Blue Cross Blue Shield. If it didn't, like we told the other caller, either you got to make them do it and tell them they have to do it. And if they're not willing to do it or won't do it, then you'll do it. And you'll get something back. You'll figure that out, and then you may be left with a little bit of a bill, but that'll be easier to pay, and you'll pay that, and hopefully no collections or anything like that. So
Correct. Okay.
that's how you have to tackle it.
And you guys cleared that up. I mean, I always listen to the station, and I heard that today, and I thought, hey, that sounds like me. Same thing.
All right, Ray. Thanks for calling in.
And
Good
thank
luck.
you so much.
You got it, man. Good luck.
Thank you.
You got it. Thanks for calling in. But for everyone else, unfortunately, we're not going to be able to do any more calls just because we're out of time. And excuse me, we're going to be off next week. And Allison, just look at the date for next week. Today's the 21st. The next Thursday is July 1st, so we're not going to be on air July 1st. We're going to be back July 8th, which is the week after. But we're not going to be on air July 1st. So to anyone who's calling in now or sitting on hold or trying to get us, off when we're not actually live, best way to get us is to send us a message through Twitter at Ribbon Health. So you just go on Twitter. People say, I don't know how to use Twitter. You just go on twitter.com and type in my name, and you'll find that, which is at Ribbon Health, and then it'll bring up our page, and then you could send me a direct message. You'll have to register to create an account for yourself to send me a message, but it's easy to do, and we do get messages all day long, every day, and we do get back to everybody, usually within 24 hours. I did get one that was a novel this week. It was like literally, I don't know how they typed it into their iPhone. So try and keep it brief so that we can read it all and answer the question. But then just know that we'll be back in 2 weeks with a whole new live show. What were you going to say, Allie?
looking forward to having a week off.
You just had 2 weeks off.
Doesn't feel like it.
No, it doesn't. No, it doesn't feel like it. But unfortunately, that's going to be the best way to get us until we're back live in 2 weeks. So again, thanks for listening in. We will definitely be back in 2 weeks. Allison Bogle, Matt Penzner, I'm Andrew Rubin on behalf of Sirius XM, Dr. Radio, Channel 110. We'll talk to you in 2 weeks.
上面有警车处理事儿呢。啊？上面有警车处理事儿呢。汽车旅馆。哦，不。哎呀，你说带个狗没地方住店，你说现在呢不用住店了。你说那个头一年出门搁佛罗里达那晚上咱找店找。
这么快？
啊，要知道那样早就那个找个窝马嘛，搁车里睡。
New channels are popping on the Sirius XM app. Indulge your guilty pleasure with glue bits. Bow down to Queens of Pop. Or unwind to acoustic sounds of the 90s and coffee house classics.
有时候真是想不开哈，你搁车里睡呗。
On the Sirius XM app.
那老晚了还转呢转呢，挨家问呢
Saturday
找
on
我。
Dr. Radio at 2 p.m. East, plastic surgeon Dr. Nolan Card reviews the latest cosmetic surgeries and procedures, including lasers, implants, facial rejuvenation, and body contouring. At 4 p.m., summer has arrived. Dr. Mark Pochafin discusses the important steps that will keep you healthy during this season of high heat, humidity, sun exposure, and other outdoor safety risks. Then at 10 p.m. East, Dr. Stacy Loeb hosts the Men's Health Show and discusses diet and kidney health. That's just some of what's happening Saturday on Sirius XM Dr. Radio.
也抵不上住店钱。
This is an important message from the CDC about vaccines. People are considered fully vaccinated 2 weeks after their second shot of the Pfizer or Moderna vaccine, and 2 weeks after the single-dose Johnson & Johnson vaccine. Once fully vaccinated, we may visit inside a home or private setting without a mask with other fully vaccinated or low-risk people, travel domestically without a pre or post-travel test, or having to quarantine after travel. For more information, please visit coronavirus.gov.
This is an important message from the CDC about coronavirus. Listen to and follow the directions of your state and local authorities. If you feel sick, stay home. Do not go to work. If your children are sick, keep them at home. If someone in your household has tested positive for the coronavirus, keep the entire household at home. Do not go to work. In all cases, contact your medical provider. Visit coronavirus.gov for the latest information from the CDC. That's coronavirus.gov.
杜鲁斯东西，那白人区，杜鲁斯东西郊区，他都是这偏远郊区，小城市，自己家原来那边有。
You the information you need to stay safe and healthy during the coronavirus pandemic. Sirius XM Dr. Radio.
This is Sirius XM Dr. Radio.
From the heart of the NYU Langone Medical Center, this is About Our Kids. Good morning. Welcome to About Our Kids, Sirius XM Radio 110. I am Dr. Lori Evans, joined by my co-host, Dr. Jess Shatkin. We have programming today for Pride Month, so we're very excited. And so let's jump right in. We have a series of really fun guests today. And our first guest, you know, this might just be, I think sometimes our producer does this to embarrass me. Peter Sokolowski, is that how you say it?
Oh, he's not answering. Oh.
Yes, indeed.
Oh.
Yes, indeed.
Okay.
No problem. I would never correct your pronunciation.
Well,
I'm
only
so offended by how you said his name, Lori.
so, it could be. But, just to let you know that, yes, he's a lexicographer who's written definitions for many of Merriam-Webster's dictionaries, active blogger, speaker on language, and he served as a pronouncer for spelling bees worldwide. And that's why I say sometimes I think my producer just asked Dr. Shatkin, Peter, how many times I have, not correctly pronounced people's names. It's gotten to the point of embarrassment, so that's why I do my best. And I'm going to call you Peter, not out of disrespect, but out of respect, so I can get that right. Okay. So this morning, you actually were on our show when "they" was the word of the year, the most looked up word, and so we wanted to continue our conversation about the word "they," also the idea of the word. Is it considered a word, non-binary? Is it a phrase? What would that be called? It's non-binary.
No, it's a word, absolutely, and that was entered in our dictionary just a few years ago, so it's fairly new in terms of the dictionary.
Ah, okay. So it is. So let's start with that. What are the word "they"? What does it mean in terms of pronouns, in terms of people's identity? How come it's become so important?
Well, it's become important because the fact is, it's very plain. Identity is important, and identity has been a subject of a lot of interest in terms of language in recent years. And I'm not telling you anything new, but what is interesting about that is those are often kind of the boring words. Words like pronouns we don't usually think of as being that interesting, but you realize they connect to our idea of ourselves, our idea of our personalities, and a term like "they." And the fact is, English has a hole in it. English doesn't have a non-specific or non-gendered pronoun for a singular. We can say "they" conventionally as a plural, but we didn't have that singular version, and that was a kind of a hole in the language. Now, we have always filled that hole with the word "they." For example, if I said a sentence like everybody likes pizza, don't they? That's completely unremarkable, and it's also hard to tell whether I'm referring to one or many people, because everybody is itself singular, right? So the fact is,
technically it's grammatically incorrect, right? Because everybody likes pizza, doesn't he? Because body, everybody is individual, single, and doesn't he, doesn't she, something like that.
Exactly. Now this is really the crux of the linguistic question. Is it grammatical? You've nailed it. And my answer to that is, first of all, your point is of course correct. Body being singular, and we say everybody is, so we conjugate it with a singular verb. But guess what? If I were referring to you alone, I would use the word "you," and I would say "you are," and that's an artifact of something else, something that's social change. Happened, something that changed in the English language as a result of social pressure. And what I mean by that is, we used to have the pronouns "thee" and "thou," and those were the singular pronouns. They were also, as you might know, the informal pronouns or the less formal pronouns. However, "thee" and "thou," so "thou art," for example, would have been the way you conjugate that. And then the plural for that second person was "you." And so English collapsed the singular and plural together into "you." And today it's unremarkable, and it is grammatical for me to say "you are" for an individual. And yet, if I say "you are" to an individual, it's impossible on the page, for example, to know whether I'm speaking to one person or several. So my point is, English has actually crossed this exact path 400 years ago when we decided to stop using "thee" and "thou."
And we don't have in our language what you're saying is a plural informal.
Right.
So a group of people, it's often that we've said, "Hey, you guys," because you have to add the guys or the gals or whatever you want to add. Usually it's the guys because you're talking about a group of people, and you don't know if it's men or women or male or female, and you don't. Without guys, you don't know if it's plural or singular. And we don't like German, although most romantic languages don't. Although German is not romantic, German has the neuter, and we don't have the neuter, which is what you're talking about. The der, die, das. The which gender is this? It doesn't matter. It's ungendered. But I don't know that any of the romantic languages have that, and we don't have that either.
No, the Romance languages don't. Most languages do have what you might call grammatical gender. So, you know, a car is feminine grammatically in French. But those, of course, are utterly arbitrary, and they really have nothing to do with, you know, with the identity of the object or the person or the thing. It's just a grammatical construct and the way those languages are put together. It is interesting that English doesn't have that. So we all kind of are presented with different linguistic problems to overcome in terms of identity.
And that's where I think it's interesting, because if you're sitting across from someone and they're talking, they use someone's name, you know, and then they use they as the gender neutral pronoun, sometimes it gets confusing for the listener. Is it your expectation that over time we will just be able to incorporate that in our understanding when people talk to us? Because, for example, you know, X went to the store, you know, and they bought, and often it's okay when it's the sentence right before, we can refer to it's, we get it, it's the person. But sometimes when people are talking, they say, yeah, they were at the store, and you're not sure if you mean a group of people or the person you're referring to. Do you think over time it'll just become like when we say you are, or, you know, will this become easier for people in general just to figure out what's being said?
Yeah, you know, language change that, first of all, language always changes. And the language changes that we notice are the difficult ones, aren't they? They're the ones that we correct our children for, or they're the ones that we think are improper or incorrect. So the fact is we are living through a moment of language change, there's no question. Now, I will say that lexicographers make lousy prognosticators. So I won't say 100%, and I'm not, you know, there's no science to this particularly. However, again, we have this earlier example of the unremarkable use of you for both singular and plural that doesn't bother anybody, even though, as you both just indicated, it is itself imprecise. So things like you guys are essential as sort of emphatic indicators of precision in English that you don't need in other languages. But we will find there'll be some version of that for they to indicate I really just mean you, or I mean a group of you, just as we do with the word you itself. So my feeling is that there were, as you might know, a lot of proposed pronouns, sort of new ones that people thought we could add to the language, and I think that's fascinating and interesting. But the fact is, I bet on the success of they simply because it's comfortable. We all already use it. It's simply adding a little bit to the way that we are comfortable with.
But it's interesting because part of me says if it were something new, it would almost be easier for me and a little less confusing. But you're saying, they is similar, so we'll get used to it.
I mean, there's a linguist in England named David Crystal who says that familiarity breeds contempt. And he's speaking in linguistic terms for the success of a novel linguistic item. Something that seems new today may not seem new even a year or two from now. And you'll see, I noticed recently, for example, that the New Yorker magazine and the New York Times are using they to identify individuals, single individuals who identify as non-binary. And so out of respect for those individuals, these publications are already using it, and it won't take long. Once those big publications do it, it will trickle down very, very quickly.
It is amazing, and I think we can speak a little bit just how language does change. I'm sure in the past year and a half you have added more words to the dictionary. I literally had a 3-year-old who was a sibling of someone I was seeing in my office and used the word asynchronous. And at first I didn't understand it because I couldn't understand a lot of what she was saying. And I'm like, what are you talking about? And she looks at me, when classes aren't like the teacher. And I cannot believe it. Asynchronous, cohort, COVID, pandemic. These are, interesting words that we're certainly used, but they are more common. Just out of curiosity, before we come back to the pronouns, which is really our kind of focus, is there a word for 2021 or 2020? The most popular word?
Well, 2020, our word of the year was, without question, the term pandemic. And big surprise there. And what's interesting to me is that it is still among our top lookups, even today in June of 2021. This phenomenon has obviously been a defining issue of our time, and the words we use, terms that are new, like COVID, for example, which was entered in our dictionary after it was coined only 34 days later, by far the fastest term ever entered in a Merriam-Webster dictionary, because it was ubiquitous immediately, it was used everywhere, and there was an urgent specificity to it. We needed to know. But there are other terms like quarantine or even isolation, or this term social distancing. They acquire new meanings for us. But asynchronous is, of course, there's nothing particularly new about that. But we have, again, a specificity that made it sort of more common. And if a 3-year-old is using it, I'm going to start using it more often myself.
You just have to go to New York City public schools where lots of things for asynchronous is here.
Indeed. And pandemic is I was going to say, this pandemic is a word that tells a story, because the dem of pandemic is the same dem as democracy. It means people, right, of the people. And the pan simply means everywhere. So,
to you about your new podcast, Words Matter. Tell us.
Yes, it is. Our motto, Word Matter, is the title of the podcast. And the fact is, I often said it backwards, and we have to retake it. But it was our idea, it was the idea of my colleague, Emily Brewster. We have every couple weeks a little group of us, 5 or 6 of us, who write short articles about words and about language for our website. We have a little what we call it a pitch meeting. We just say, okay, each of us has to write 3 or 4 articles in the next couple of weeks, and we want to make sure we all know what subjects we're writing on, mostly so we don't duplicate, or that we can, more importantly, contribute to each other's ideas, so that if someone says, I'd love to write about the history of a certain word, someone else can say, hey, I know that history, and it involves, for example, the Norman Conquest, just some detail that makes it interesting. And so my colleague said, those conversations are really fun. They're a highlight of my week. Why don't we record them and see if other people like them too? And the only difference is we record them after we've done the research, rather than the pitch, so that we have the story with a beginning, a middle, and an ending. So what we did was then get together with our local NPR affiliate, New England Public Media, right in Springfield, 1 mile from the offices of Merriam-Webster, and they were interested in producing a podcast. So now we had a place to go as a studio with good sound and all that, the good production. And so the 4 of us, Em and Shay, Neil Servin, Emily Brewster, and myself, we get together and have these conversations. And at first, I have to tell you, I was worried it might be a little boring, like a little too inside baseball. But it turns out we're approaching our 1,000,000th download in less than a year. So it turns out people like it, and I'm thrilled. And so we through the pandemic, we've had some difficulties. Sometimes there's only 2 of us chatting, and we've also used some remote technology that the radio people have offered us. So, but we have kept the new episodes coming every Wednesday.
So you know what, Peter, I think you are just like us. Our origins of when we started Dr. Radio, it's like, really, are people going to listen to Jess and Lori talk about psychiatry and psychology? Or I always thought, are we more entertaining than the urology show? You just never know. Who's going to call us? I don't know if we have 1 million downloads, but we'll have to figure it out.
Well, what's interesting is, it turns out that, and I've learned this kind of slowly and honestly and earnestly, which is to say that writing dictionaries is a quiet job, and for the most part, our office, when I started, 40 editors working all day, every day on the dictionary, but you could hear a pin drop. Because there was a powerful culture of silence. People didn't interrupt each other, because it's sort of like, it's like taking a test. It's that kind of mental effort. You don't want to interrupt someone. So we had a tradition before email of writing little notes to each other, just so no one was interrupted in real time. Now, of course, email and Slack have replaced that. But the fact is When I started going out and meeting people, going to conferences, speaking as a keynote speaker, or going to publishing conferences of educators or librarians, what I discovered was that this quiet pursuit, this quiet interest in language is something that a lot of people share, but they had nowhere to put it. Until social media, it was hard to find each other. And now it turns out we're about 1 million followers on Twitter, and we have more than 1 million people who subscribe to our word of the day as an email that they get every day. And so the fact is, there's a lot of us who love language, and we've only sort of just realized this, and we're connecting with more people in more different ways.
And do you know what our producer? No. And the idea is, yes, language maybe can be spoken, not just written about Slack. So I wanted to let our listeners know they're listening to Dr. Radio, Sirius XM 110, Lori Evans, Jess Shatkin, and our special guest, Peter Sokolowski. Just say it for me. That's how it's
Sokolowski, we said.
Okay. Let me say. The editor of Merriam-Webster, lexicographer who's written definitions for many of Merriam-Webster's dictionaries, and an active blogger and speaker on language. We're talking today about some of the newer terms when it comes to the LGBTQ community, including they and them and non-binary. What about things like genderqueer or gender fluid? Are they being also included? How are these in the dictionary? I should look these up. Okay.
No, they absolutely are. That's a great question, and genderqueer is in the dictionary for sure. There's a simple rule, and it has nothing to do with the actual meaning of any given word, or it simply is, if a word is used by lots of people in lots of publications, it goes in. So there's very little sort of discussion. We don't have a committee or advocacy. If we notice a term is used in many publications by many different writers, in other words, it's not just an idiosyncrasy of one publication or one writer, but used by many people to mean the same thing, then that means it's logical that at some point people will want to know more about that word, to know its definition, to know its origin. And so it goes into the dictionary. Genderqueer has been in the dictionary for a number of years, and it's a nice little definition. It says, of relating to or being a person whose gender identity cannot be categorized as solely male or female. And a very straightforward explanation, which is why people come to the dictionary. I think very neutral and objective observations about language.
And what's the definition then of non-binary?
Non-binary is something that we added just in 2017, and it turns out the term in its more technical use goes back to 1863 or so. But basically, non, of course, is a familiar negation, right? So non-binary, we entered binary forever. So non-binary means not binary, but then we split it into 3 definitions. 1, not restricted to 2 things or parts, like non-binary voting, and which you just experienced in New York, I believe. And B, of relating to or being a system of numbers that does not use 2 as its base, so non-binary math. And then finally, number 3, or C, relating to or being a person who identifies with or expresses a gender identity that is neither entirely male nor entirely female. And so that's our, again, straightforward definition. And it was because of that use that the term was finally added to the dictionary. And the way this works is that even though the most recent use is maybe the one that we're talking about today and is the one that most people notice, those older uses also get added when we add a new term to the dictionary, because they've been around for a while, they're in print, and we want to make sure people know the full definition of a word, all of its meanings.
It's impressive. We'd love to have maybe anyone want to give us a call and let us know a word that maybe stuck them that their kid used, that they're trying to figure out what it really means, or what it means in the context of who their child is. We can be reached at 1-877-NYU-DOCS. That's 1-877-698-3627. So in adding to these words, like when we're talking about Pride Month, are there any words that surprised you about how quickly they became used in those terms, like, or how quickly they got added to the dictionary?
all of these terms were added relatively quickly, and I think that's because that's an artifact of the internet. The fact is that we spread information much more quickly than we used to. It used to take, decades for a word to go from coinage to entry into our dictionary. And now, because identity issues are often written about, and especially when celebrities use these terms. And so, for example, recently it was Demi Lovato who came out as non-binary and sent our data spiking for terms like they and non-binary. So when that happens, when prominent people make these kinds of announcements, they get covered in the press. And so that accelerates the process, because if we see a term is used in big publications, the Wall Street Journal, the New York Times, the Atlantic Magazine, Harper's, if we see a term used in these publications, that does accelerate the process. That means that we really need to get this into the dictionary soon, because if these big publications are using it without explanation, and that's an important point, as soon as people stop using parentheses or quotation marks or italics or any kind of linguistic white gloves to explain these terms, as soon as they were used in just fluent writing and simply as unremarkable, citizens of the language, that means that it's really ready to go into the dictionary. So the answer is yes, these terms, like older terms like transsexual, they were added relatively quickly to the dictionary because the conversations happen relatively quickly.
And that's it, in some ways, I think having it in big publications, being out there more commonly, is really going to help parents, because sometimes I think parents struggle, when they have non-binary kids who choose to use the they them pronouns. Often parents will make errors, part of because this is not the pronouns they were using as the child was raised, it's a change, or they're just like me and use whatever name comes to mind, and it may not be related to any of the children, it may be, your pet's name. But I think as it becomes more common and used in general, I do think parents will become more comfortable with it. In general, just the language of it. Just what have you found with parents who have either transgender kids who are using they them pronouns? What's it been like for them?
Well, I agree that language change that we notice, there's lots of language change that we sort of don't notice, things that happen and they happen so naturally that, for example, access was never a verb until, very recently, and now we use access as a verb constantly for Wi-Fi or, internet connection. And that happened without anyone particularly complaining or noticing. But of course, we're all going to trip over this at first, right? Because, as you say, we're not used to it. Language change that's conscious and that's socially driven has to be at some point conscientious. That is to say that we have to do it deliberately until we don't think about it, and that's true about language. Language is a habit. It's just that simple. Language is a habit, and we are simply acquiring a new habit of language, and that will take a different amount of time for everybody. That depends on exposure, that depends on interest, that depends on willingness, it depends on lots of other things. And my point is that those are cultural elements, they're not linguistic elements. In other words, the linguistic part of this is the easy part.
But it is something that we're changing all the time, our language. One of the things that drove me crazy 30 years ago and still kind of grates on my eardrum is as per.
There we go.
This phrase, as per. There's no, technically, that's incorrect grammar. It's as so-and-so said. It's per so-and-so said. There's no as per. But some engineer somewhere or somebody who sort of, who didn't like to talk technical speak kind of came up with this as per. And this has just become common language, and you have to accept it, right? Make the hair on my neck stand up just a little bit, but this is what happens with language, and if you don't adopt what's changing, then you get left behind. My parents are in their mid-90s and healthy, and the health part is probably a mixture of good fortune and exercise and all that stuff. But the fact that they've stayed culturally alive and that they want to still live, I think is because they got email addresses and they got iPads and they entered the era of what we're dealing with now. They know how to use Zoom. And without that, you sort of, the world passes you by. You know, my aunt is 100, and she's mostly bedridden, but she reads the New York Times every day, and she watches baseball all day long. And it's like, she just like, that keeps her going. You know, that she just has a reason to wake up in the morning. And I think that if you don't stay a part of the culture in some way, and the language is emblematic of that, I think that you run into trouble. And I think you sort of say, why am I alive? I'm not making children anymore. I'm not providing for anybody else but myself. I'm just sort of using up space. So I think that language is another example of how we need to sort of adapt and change over time. Just like the weather changes. We put on a new coat, or we put on an old coat, whatever, but we change with the weather, we change with the language.
Absolutely.
I think parents have a hard time with it. I think that sometimes I have a hard time with it because...
No, we all do, because, you know, what you are seeking with as per, I love that. Everybody has a little peeve, and everybody's is different, and I love hearing about them. But as per, you know, that bothers you because there's a logical problem with it, right? It doesn't really correspond to logic. And my point only is just to, and of course, I always say everybody has every right to hate any given word. there's no problem with that. What I would say, though, is that language, and especially English, isn't logical. So, in other words, English has its own kind of logic that's inherent only to English, and that's why we have strange things like irregardless, the term irregardless, which is obviously, you know, a double negative or a hypercorrection, whatever you want to call it, and yet it persists in the English language. We, you know, that's just an artifact of the language, not conforming to logic. And my point only is that we have to sometimes separate logic from language.
Then arrive at destination. Right, and I think, just out of curiosity, language does change over time. Some words that were accepted and, you know, positive. Have you ever actually, have words been removed from the dictionary, or when there is an offensive meaning that comes on, is that added as well? How do you handle those?
Turn left.
Sure, those are great questions. You know, in the past, when print was the medium, the only medium, and we still sell a lot of print dictionaries for sure, but when print was king, yes, of course, we had to remove words from the dictionary to make room for new and maybe more urgent terms. And the words that were removed were typically really boring and usually what we call compound words. So, for example, I remember recently the term plantsman, meaning gardener. Plantsman was removed because it had been used in Shakespeare's day, for example. It's fairly transparent what it means, and if anyone's really interested in it, they can look up the word in older dictionaries or bigger dictionaries, you know, an unabridged dictionary, for example. However, online we don't have space restrictions, and so we don't remove terms. You know, we keep them because the English language, someone is going to encounter this word and want to look it up. The dictionary is, sometimes I call it, a very long tail. You know, there's a lot of words that are looked up thousands and thousands of times per minute at the top of the list, and then there are words that might be looked up once every 3 years at the bottom of the list. But I'm glad they're there too. You know, the language is big. In terms of offensive meanings, absolutely, we always add them. There's no censorship in the dictionary, but we do add usage advice, which is to say, will you embarrass yourself or offend others with the use of this term? That's very important, and so we will label a word as being offensive or usually offensive, just as we would label it for its region if it were, for example, usually British. So we just look at those in a very neutral way and label them as they are used in real life.
This is why the dictionary